Hello and welcome to Parkinson Place Virtual Summit 2021. Welcome Parkinson Place members, care partners, and new friends tuning in to our inaugural Virtual Summit. I'm Alex Redmond, CEO of Parkinson Place, and I'm so happy to be here with you from the safety of your home to learn more about programs, treatments, products, and educational opportunities for people living with Parkinson's disease. We've assembled some of the best speakers making a difference in the lives of people with Parkinson's. And now, a little about Parkinson Place. Since 2012, we have served as a free resource offering the finest evidence-based educational and empowerment programs to improve the quality of life for both members and caregivers. Amid the pandemic, Parkinson Place shifted all programming online through Zoom. And now we host more than 65 free programs per month. Those include Rocksteady Boxing, Brains and Balance, Yoga, Pilates, Tai Chi, stretching, dance, fitness, speech, and more. You can join Caregivers Only Club or participate in men's and women's peer groups. Those are exclusively for people living with PD. Expert speakers present ongoing educational conferences and special events. Again, everything is free. Visit parkinsonplace.org to find out more about all we offer. We're able to bring you the Parkinson Place Virtual Summit 2021 free of charge thanks to the generous support of our sponsors and people like you, committed to engaging and informing Parkinson's patients and care partners. One more thing. When you registered for the summit, you became eligible to be one of 5 people to each receive $500. And now, it is my pleasure to introduce Dr. Kelly D Foote. Dr. Foote is a professor of neurosurgery of the University of Florida College of Medicine and co-director of the Norman Fixel Institute for Neurological Diseases at UF Health. He's one of 5 neurosurgeons with fellowship training in both movement disorders neurology and deep brain stimulation, otherwise known as DBS. Dr. Foote has performed nearly 2,000 DBS lead implantation surgeries since joining UF in 2002. He's published more than 185 peer-reviewed research articles in the fields of deep brain stimulation and stereotactic radiosurgery. Please welcome Dr. Foote.
Thank you, Alex, and thank you everyone at Parkinson Place for giving me this opportunity to spend some time with you. I actually really enjoy talking to patient groups. It's a lot more fun than giving lectures to doctors. As you might imagine, neurosurgeons tend to be a bit on the arrogant side. We'll talk more about that. But actually, as an introduction, I would like to share with you my favorite neurosurgery skit by the British comedians Mitchell and Webb.
Oh, Lionel, glad you could make it. Can I get you a drink?
Yeah, something soft. I'm driving. Parking's an absolute nightmare around here, isn't it? Had to reverse into the tiniest of spaces. Still, I managed it. I mean, parking's not exactly brain surgery, is it? And I should know.
Why is that? Are you a doctor?
Careful, not a doctor. I'm a brain surgeon. Big difference. Big difference. Yeah, I actually know a joke about this. What's the difference between a doctor and a brain surgeon? One's not exactly brain surgery. The other is brain surgery. So, what do you guys do?
I'm an accountant.
Oh, that's good. Yeah, I could do with an accountant. Filling in those tax forms can get really confusing, can't it? Still, it's not exactly brain surgery, is it? I mean, brain surgery, believe me, is very complex. Are you an accountant too?
No, I work for a charity.
Oh, that's a very selfless job, isn't it? I really admire you. I don't think I could ever do what you do. I say that because it's emotionally draining, not because it's hard. I mean, it's not exactly brain surgery, is it? Which, as a brain surgeon, is what I do.
Lionel, here's your drink. Lionel's brain surgeon, you know.
Yeah, he mentioned it.
Oh, Jeff, they keep you late at the Space Centre.
As always.
And this food rounder. Have you met Lionel?
No, hello, Lionel.
So, Jeff, how do you earn a crust?
Well, I'm a scientist. I work mainly with rockets. It's pretty tough work. What do you do?
Why, I don't mean to boast, but I'm a brain surgeon.
Brain surgery. Not exactly rocket science, is it?
I assume you're laughing. That's one of the weird things about these online presentations is you can't experience the feedback. And so when you tell jokes and no one laughs, or at least you can't hear them laughing, it feels like the joke didn't hit. In any case, I can't imagine that you didn't laugh at that. Actually, I think it's not too surprising if you think about it that neurosurgeons tend to be on the arrogant side. It takes a fairly confident person to cut someone's head open and tamper with their brain, considering the consequences if something goes wrong. So I mean, I'm not excusing most neurosurgery bad behavior, but I'm just saying it may not be that surprising. In any case, I always smile when I give one of these talks and someone comes up to me after the talk and says with surprise in their voice, you know, you're a neurosurgeon and you're such a nice guy. And I think, well, you know, the expectations are so low for neurosurgical behavior that all I have to do to be the nicest neurosurgeon you've ever met is just not be a complete asshole. So what Alex has asked me to do for an hour or so is essentially an interview. She sent me a list of questions from the crowd, and I'm going to read your questions and see if I can answer them. I may actually share some slides, some PowerPoint slides to illustrate certain points if I have some that I think will be useful. Okay, so let's jump right in. Question number 1. What exactly is DBS, and is it a cure for Parkinson's disease? Well, the second part of that question, sadly, the answer is no. DBS is not a cure for Parkinson's disease. DBS stands for Deep Brain Stimulation, and it is sort of exactly what you might think it is based on that name. It's the delivery of electrical stimulation deep into the brain in the case of Parkinson's disease, to one of 2 carefully selected targets that are essentially part of a malfunctioning circuit that causes the symptoms of Parkinson's disease. And while DBS doesn't cure the underlying problem that causes Parkinson's disease, it can quite effectively diminish the symptoms, the cardinal motor symptoms of Parkinson's disease, like tremor, stiffness, slowness, even muscle cramps from dystonia. It can even diminish some of the side effects of the medications used to treat Parkinson's disease, like dyskinesia, those extra involuntary movements that some patients with Parkinson's disease get after they've taken the dopaminergic medications like Sinemet. Take a look at this slide. It's an illustration of what a typical DBS system looks like. It consists of a pulse generator that's implanted in the chest wall under the skin below the collarbone. That pulse generator is mostly a battery. Most of the volume of the pulse generator is taken up by the battery. There's also some important circuitry that programs the parameters of the pulses that are delivered to the brain, the electrical pulses, and this device can be programmed through the skin with a programmer. The pulse generator is connected to an extension wire that is tunneled under the skin, up the neck, behind the ear, and up under the scalp. It plugs into the third component of the system, which is the DBS lead, which is a wire that goes under the scalp through a hole that's drilled in the top of the head and down into the brain to the carefully selected target to deliver the pulses of electricity to that malfunctioning brain circuit in order to hopefully alleviate symptoms. And it's critically important, of course, to get that stimulating electrode in the brain in just the right spot, so that stimulation covers up the bad signal, if you will, with white noise, and allows the rest of the functional circuitry to work better. If it's not in the right spot, then of course it will disrupt normal information flow in the brain and cause side effects of some kind. Question number 2. Should everyone with Parkinson's disease have DBS surgery? If not, how do you decide who is likely to benefit from DBS surgery and when they should have it? Is it risky? Well, these are really important questions and sort of get to the heart of what's the role of DBS in the treatment of Parkinson's disease. So here I'd like to actually use a few illustrative slides to sort of go through an explanation of how I think about Parkinson's disease and when DBS comes into play effectively. Most of you understand that one of the fundamental problems of Parkinson's disease is an insufficient supply of dopamine in the brain, specifically in the motor circuitry in the brain, the part of the brain that enables us to move the way we want to move. And we're all born with a supply of dopamine-producing neurons in a structure called the substantia nigra. We have one on each side of the brain, and this side of the brain controls this side of the body, and vice versa. And over time, we lose those dopamine-producing neurons, and the substantia nigra degenerates. And if we lose enough of them, then we will eventually develop symptoms of Parkinson's disease. So how do you treat Parkinson's disease? Well, you replace the dopamine that's insufficient in the brain. So this has been one of the miracles of modern medicine, dopamine replacement. The medicine that most of you are familiar with is carbidopa-levodopa, or otherwise known as Sinemet, and it works amazingly well. But there are limitations. Over time, as your native dopamine supply continues to gradually get less and less and less, you have to take more and more medicine just to achieve a therapeutic level. So the dosages of dopaminergic medications gradually have to increase over time, and along with those increasing doses come increasing problems with side effects like dyskinesia and hallucinations. And the effect of the medications become less predictable over time. They wear off at unpredictable times, or you may take your medicine and it doesn't have the effect you would like it to take. It becomes more sensitive to how much protein you ate, how much sleep you got, and as the effects of the medications become less predictable, your quality of life goes down. So I want to start with a little pharmacology lesson. So take a look at this slide. I've labeled it Pharmacology 101. This is a slide that every medical student learns, and it's fairly straightforward. It's a graph, and on the vertical axis of the graph is the concentration of some medication or drug in the bloodstream. On the horizontal axis is time. So what I've depicted here is at time 0 you take a pill, and that results in a gradual increase of the concentration of that medication in the bloodstream, because you take the pill, you swallow it, it goes down your throat, gets in your stomach, gets pulverized a bit, gets out to your small intestine, where it gets absorbed into the bloodstream gradually, and the amount of that medicine in your bloodstream gradually increases to some maximum amount that you get into your system, and after it peaks out, your kidneys, their job is to notice things that don't belong in the blood and to filter it out. So the kidneys will say this is something that's not normal, and your kidneys will gradually get rid of that medication if it's cleared in the kidneys. So to illustrate the point, if you have a headache, you take an aspirin, and it takes 15 to 30 minutes for enough of that aspirin to get into your bloodstream to alleviate your headache. And in this graph here, you see the dotted line where the orange line goes up and it crosses over the dotted line, and it goes from the subtherapeutic range where there's no effect into the therapeutic range, or the therapeutic window, where your headache feels better. And as long as the peak amount doesn't go too high into the supertherapeutic range, you don't get side effects and your headache feels better. But eventually, the amount of aspirin in your bloodstream will gradually go away, and the concentration will drop below that line again. And if whatever was causing your headache in the first place is still there, your headache comes back. So you might, if you're someone who gets headaches that don't go away, say until you sleep for the night, and you have a headache in the morning, you might say, I'm going to take an aspirin every 5 hours today, so that the effect of this one, as it wears off, it'll be replaced by the effect of this next one I take. So you keep the amount of aspirin in your system high enough so that you don't get the headache back, and then you go to sleep that night and you wake up in the morning, you're okay. So that's illustration of pharmacology. So in Parkinson's disease, of course, the concentration we care most about is dopamine. And as our native supply of dopamine diminishes, we're going to replace that with Sinemet tablets, or carbidopa-levodopa, and have a similar effect. And what I've illustrated in this slide is early Parkinson's disease. So I've shown a person who, as is pretty typical in early Parkinson's disease, takes 3 doses of Sinemet per day, maybe 1 tablet 3 times a day, and the amount required is not very high in order to get him relief from stiffness, slowness, tremor, freezing, dystonia, and pain, as seen in the subtherapeutic range, and to get him into that therapeutic window. And in early Parkinson's disease, dyskinesias and hallucinations as side effects of the medication are very uncommon. And it takes quite a lot to cause any kind of those symptoms. In fact, in early Parkinson's disease, most people don't ever get those symptoms. In the next slide, however, I will depict what happens over the years as Parkinson's disease progresses. The amount of dopamine that you're producing in the brain gets less and less and less, unfortunately. So the amount that you have to take in the form of pills to replace that and to be able to function increases over time. So if you look at the graph, that therapeutic window that in the previous slide was very wide is now quite narrow, because it takes a lot of medicine to get relief from the symptoms. But now, over time, your brain, which is starved for dopamine, becomes hypersensitive to dopamine, and you are more prone to developing dyskinesias and hallucinations as side effects due to upregulation of dopamine receptors in those neurons in the motor system that require dopamine to do their job. So, in any case, what this results in is a phenomenon called motor fluctuations. And what I mean by that, fluctuation means wave. So as you take your medications, despite increasing the dose or increasing the frequency or all the other manipulations of your medication regimen that the movement disorders neurologist might make, it becomes increasingly difficult to keep your dopamine level inside that narrow therapeutic window. So if you have motor fluctuations, you're someone who now spends a significant amount of your day either subtherapeutic or supertherapeutic. So, and you might fluctuate back and forth with every dose of medication. So you spend most of your day either stiff and slow or shaking, or having dyskinesias and or hallucinations. And you have brief intervals throughout the day where the concentration of dopamine in your brain is about right, and you function reasonably well, but it becomes increasingly frustrating. So what's the role of DBS? The next slide, I've represented DBS as a horizontal line right through the therapeutic window. What I mean by that is, unlike the pills that you take that necessarily gradually go up and come down, DBS is an electrical device. We can turn it up, we can turn it down, we can adjust the settings, and we can find a setting that helps, and then we can just leave it there. And it will have a continuous effect, a continuous therapeutic effect that's similar but not identical to the effect of dopamine or Sinemet. And if you're a mathematician, you know that if you take a sine wave and a horizontal line and you add them together, you get a process called dampening. So if we look at this next slide, this is what happens. Instead of those big fluctuations, DBS makes it so your lows become less low and your highs become less high. Your symptoms aren't as bad when your medications wear off, and your side effects aren't as bad either. And you spend much more of your time in that therapeutic window with a higher level of functioning. So essentially what this translates into is an understanding of DBS as the main or the most common indication for DBS surgery is motor fluctuations. And it also helps you understand that DBS doesn't cure Parkinson's disease. In fact, it doesn't even necessarily make you significantly better than you are when you're at your best before DBS surgery. But what it does most effectively is get you at or near your best level of functioning and keep you there much more of the time, which, if you have motor fluctuations, results in a dramatic improvement in your quality of life. So when I explain this to patients who are considering DBS surgery, and their eyes light up and say, "Oh my gosh, that would be amazing," I know that they're patients with motor fluctuations, and I sort of get excited about the prospect of improving their quality of life. So I thought this would be a good time to show a slide with some video of a man who had DBS surgery. And what I've done here is edit these two videos, one of him on the left side before DBS surgery and off his medications, trying to perform the various tasks that most of you are familiar with, tapping the fingers and rotating the hands, so the UPDRS that you may be familiar with. And on the right side, as you can see, he is much more successfully accomplishing those movements that we were asking him to make, and he is also off his medication in that video. So you can see sort of the effect of DBS surgery on this man's ability to move around, and as you might imagine, when this sort of thing happens, it's very gratifying, and it makes a big difference in the patient's quality of life. Here, one more slide of a patient before and after DBS surgery. This is an unusual case of a woman who developed Parkinson's disease at a very young age, and she had severe dystonia. And dystonia is essentially disorganized message from the motor circuitry in the brain to the muscles that makes the muscles work against one another, and can result in unusual postures. In her case, as you can see on the left-hand side before DBS, one of her arms was involuntarily elevating, and she couldn't stop it. And she would actually reach up and pull it down, and as you might imagine, that gets tiresome. After DBS, obviously I'm showing you this video because she had just a wonderful effect, and it essentially solved that problem that when her medications would wear off, she developed these crazy postures in her arm, and she was very happy about that. So I think that's the first part of that question, and that was a pretty long-winded answer. I apologize for that. But there was another part of that question that I think is also really important, which was how do you determine who should have DBS surgery? Who is a good candidate? Or the other way to say it is, who is most likely to benefit? Now, I just explained someone who has motor fluctuations. Other common indications are medication refractory tremor, so tremor that just doesn't get better or is insufficiently alleviated with medication. DBS is actually quite effective at suppressing tremor, so that can be an indication for DBS surgery all by itself. The other concept I would like to introduce is this notion of a risk-benefit analysis. So we have an approach at our center, and I have to say I'm very spoiled. I have a giant team of people who work with me, and we're all co-located in the same facility. And I have specialists in all the different domains that people with Parkinson's disease might need. And our approach to evaluating someone as a candidate for DBS surgery is what we call a multidisciplinary or interdisciplinary risk-benefit analysis. So if you're referred to our center for DBS surgery, typically you'll be seen first by a movement disorders neurologist who's an expert at DBS and an expert specifically at identifying someone who's a good candidate for DBS. And if that person thinks that you're a potentially good candidate for DBS surgery, then you get referred to what's called fast track. And we call it fast track, even though it takes 2 or 3 days to accomplish. It's very fast compared to how it used to be. And what fast track consists of is essentially an evaluation where you meet with 9 or 10 different Parkinson specialists of different types who are all also DBS experts. And they have evaluated hundreds of patients both before and after DBS surgery in their domain of expertise. So, for example, a physical therapist. So the physical therapist here is a Parkinson specialist and knows all the nuances of Parkinson's disease and how it affects your ability to get around, and also how DBS tends to affect your ability to get around in both positive and or negative ways. And the physical therapist might evaluate you, and then when we get together and talk about the patient after the patient goes home, the physical therapist might say, Mrs. Jones has this issue with her walking, and from past experience, I can tell you that when the patients have this issue, this specific issue with their walking, if we do the DBS surgery this way, they tend to do quite well. But if we do it the other way, it's very common for them to develop this problem. So my suggestion is that we do it this way. And as you might imagine, for me, that's terrific, especially because it's not just the physical therapist. It's actually the speech and swallowing expert, the neuropsychologist, the person who evaluates your cognitive function, the psychiatrist the person who is an expert at the limbic problems that Parkinson patients commonly deal with. The issues with judgment, impulse control, depression, etc. So neurology, neurosurgery, physical therapy, occupational therapy, dietary experts, neuropsychology, which is the cognitive function experts, psychiatry, and I'm sure I'm missing a couple of the others, social work, and all of these people say, I think social work's an interesting one. Why do I have to see a social worker? Well, the social worker will come to the meeting, and when we talk about this particular patient, she might say, Mrs. Smith lives alone, but she has a very nice support system, and her son is just down the road, and he was there, and he said he'd be happy to bring her to her appointments, and I think she'll do just fine. But for another patient, she might identify, this person is going to have trouble because of her social situation and is going to need some help, and we need to address these issues up front so that we can make sure everything goes the way we want it to. And so we basically try to think about all of the potential risks and all of the potential benefits, and we talk about them together. We have experts in all the different domains, and then collectively at this meeting that we have a couple times a month to discuss DBS candidates, we come to some consensus about what to recommend to help each patient. And that introduces a very important notion to us, which is that deep brain stimulation is most effective when it's tailored to the specific needs of each patient. And that's a theme that will come up over and over and over, and I think it's critically important. Question 3. Can you describe the operation? I've heard the patients are awake. Question mark, exclamation point, question mark. Sure. I'll describe the operation, run through it, and yes, actually, in the vast majority of our patients, they are awake for the entire operation. The reason for that is we think that it is safer and more effective, and it's tolerable. I'm not going to say it's a great, easy experience, but it's not painful. That's I think a critically important thing to understand. The reason that you can be awake while we're drilling a small hole in your skull is that your skull has no sensation. There aren't any sensory nerve endings in your skull. So you hear the drill, you'll feel the vibration while the drill is making the hole, but there's no pain associated with that. Likewise, the brain itself, interestingly, despite the fact that there are billions of neurons in the brain, none of them are sensory. There are no sensory nerve endings in the brain. So as we pass these little probes through the brain, you can't even tell we're doing it. You can't feel a thing in your brain, which is sort of weird and sort of fascinating, but absolutely true. So the only thing that causes any pain is the skin. Of course, your skin, your scalp has a bunch of sensory nerve endings, and we have to inject local anesthetic or numbing medicine to desensitize your skin. And once it's numb, I'm sure most of you have had local anesthetic before at some point in your lives. Once it's numb, it doesn't hurt. So in order to go through the entire surgery awake, the only pain that you experience is a few shots of local anesthetic into the scalp, each of which hurts for about 5 seconds. I think one thing that most people are nervous about is the attachment of this, we call it a head ring, a stereotactic head ring, and we attach it to your head with 4 pins that push through the skin, 2 in the forehead area and 2 in the back of your head. These pins push through the skin and hit the skull. They don't go through the skull. But obviously, if I just pushed pins through your skull, through your scalp, that would really hurt. So I inject numbing medicine at those 4 spots before we attach the ring. The numbing medicine hurts for 5 seconds 4 times. I figure I've put on somewhere between 5,000 and 6,000 of these rings in my time, and patients tolerate it just fine. The shots hurt for a few seconds, but as long as I prepare the patients for the experience, they're fine. Interestingly, the shots that we do where the incision is made on top of the head, those shots don't really hurt much because we've already given a numbing medicine shot here, and the nerve that supplies sensation to the top of the head passes right through here, and that first shot makes the top of the head mostly numb. So the shots during the operation don't really hurt as much. In any case, when we attach the head ring, for about a minute to 2 minutes, you feel an uncomfortable pressure or tightness, like it squeezes quite significantly. But interestingly, your brain accommodates to that squeezing, and within a minute or 2, you don't feel it anymore, and then you've just got this weird hat on. It's a little bit heavy, and until you get into the operating room, you have to hold it up. But once you get into the operating room, it holds you up, and it makes it so you don't have to worry about holding still because it's kind of bolted to the table. It holds you nice and still. So holding you still is one function of the ring, but the more important function of that ring that's attached to your head, the way we do the operation, is it's the frame of reference for the computer guidance system. So we take an MRI scan, actually several MRI scans, high-resolution pictures of the brain, to make a computer model of your brain, and then in virtual space, you've heard of virtual reality. Well, this is a virtual reality exercise. We do the operation, we choose the target very precisely in the MRI, and we choose a safe trajectory to get to the target through the brain. Once we have it exactly the way we want it on the MRI, we need to translate that from virtual space on the computer to real space in your head in the operating room. And that ring is the way we do that. So we, on the day before surgery, we get the high-resolution MRI. We do the operation on the computer. On the day of surgery, we attach the ring, and we get a quick CAT scan. And then the CAT scan is fused to the MRI scan. So now that ring exists both in virtual space and real space. And and the computer guidance system in the operating room that does the aiming for us attaches to the ring and can translate the operation we did on the computer to you. Interestingly, I would argue that the part of the operation that's done on the computer is the hardest part for us. Once we get that just right, the part in the operating room is pretty straightforward. One of the issues that people should know about, if we're talking about how we do the operation, is if you use intraoperative neurophysiology like we do to make sure you're in the right spot in the brain to get the best outcome and have the fewest side effects, it's very beneficial for the patient to be off their Parkinson medications. When you're off your Parkinson medications, the abnormal signals in the brain from those 2 targets that we tend to choose are much more robust and easier to see when we do our testing. So to be honest with you, for many patients with Parkinson's disease, the worst part of the whole operation is being off their medications all morning as they're going through the procedure. And what we do is as soon as we're finished with the physiologic testing, we give you some Parkinson medication and try to alleviate your Parkinson symptoms. But for many people, being off their medications during the procedure is really the most uncomfortable part of the whole process. The recovery is essentially, you're awake the whole time. So at the end of the operation, we take the head ring off, we wash the soap out of your hair. There's an incision where the burr hole is that's sewed up with the absorbable sutures on the inside and staples on the outside. I tend to just cut a small strip of hair. I do a procedure to make it so that the DBS cap, the covering over the hole that holds the DBS lead in place, doesn't stick out. So we do a little extra drilling to countersink that cap so that when we sew the scalp back together over the top of it, it doesn't stick out, and patients much prefer that, especially men who may have a receding hairline. And they don't want to have this crazy bump on top of their head for the rest of their life that they have to explain to every stranger that they meet. And those bumps actually have a downside as well. As we get older, our scalp thins out, and in some patients, after they've had DBS for a long time, as the scalp thins out, that lump under the scalp can erode through, and you can end up with the plastic cap sticking out, and it becomes contaminated, infected, and can lead to a bunch of very unpleasant adverse effects. So we're very careful to make sure there aren't any bumps anywhere. At the end of the lead implantation procedure, we actually do intentionally put a bump on the end of the wire. We attach a dummy connector that's not plugged into anything, and we tuck it under the scalp so that there will be a bump on the back of the head where the end of the wire is, to help us find the end of the wire for the next procedure when we have to connect it to the pulse generator that we implant in the chest. And that procedure we have to put you under general anesthesia for, even though we would rather not. Just tunneling under the skin to run that wire up the neck would be exceptionally unpleasant if you were awake. So that one we put you to sleep for. But at that point, it's not brain surgery. The first operation, we watch everyone overnight in the hospital, and the vast majority of people go home the next day feeling essentially pretty similar to how they did when they came in, maybe with a little headache. And then for the second procedure, to put the pulse generator in, we put them to sleep, we wake them up, and because it's all skin surgery that day, that's an outpatient procedure, and they can go home that day. I just mentioned 2 procedures. That's if there are... our typical protocol is staging. What we have learned in our practice, the way we do the operation, patients tend to do better with multiple small operations rather than one giant operation. They're just better tolerated. They tend to, as I said, to go home the next day instead of spending a week in the hospital trying to recover from a big operation, or going to rehab for a while. Our typical bilateral DBS implantation involves a lead implantation procedure on one side, come back a month later and put the lead in on the other side with the similar procedure, one overnight stay in the hospital for each of those, and then a few weeks after that, a pulse generator implantation running 2 cables, plugging in those 2 leads. So 3 procedures in the space of 2 months, staged, and most people tolerate it very well with a relatively small footprint on their life. So that's my description of the surgery, and yes, for us, most of the patients are awake. I should probably say something about that. It is a bit controversial, especially these days, because the imaging and the targeting software and much of the technology that we use to do the virtual operation has gotten better and better, and the stereotactic equipment has gotten better. And many centers that implant DBS systems have decided that they don't need intraoperative physiology to optimize the outcome, and so they are offering DBS surgery asleep. Interestingly, it ends up in some places being a big marketing ploy, because surprise, if you ask 10 people on the street, I'm going to drill a hole in your skull. Would you rather be awake or asleep when I do that? It's very rare to run into somebody who, without further knowledge, would say, "Oh, I think I'd like to be awake for that." The obvious impulse is to say, "Well, I think it would be much more pleasant if I were asleep." And even though it may be more pleasant, it's not painful. And if I told you that if you're awake, you won't have any pain, and the likelihood that you will be happy with the outcome of your surgery will be significantly higher, then you might think twice about whether you want to be awake or asleep. Anyway, this is controversial, and you'll hear different things from different people. But so far, using our methodology, we believe we get better outcomes for our patients when we keep them awake. We've gotten really good at managing the anxiety part of it, which is honestly the hard part. It's not a problem to manage the pain because there's not much pain, but we have a whole system of managing anxiety that is sort of fun, actually. During the operation, I have 2 video monitors in front of the patient. One of them has a camera feed so that if they want to, they can watch the operation and what's going on. And on the other one, we have Netflix, and they can watch a movie or they can watch a series that they like. So they got 2 monitors. Usually we have the one TV with subtitles, and they can choose a music selection, basically any music that calms them or that they like to listen to. That helps with the anxiety. And we tend to keep a pretty lighthearted attitude in the operating room. It's not a stuffy, highly formal environment, which I think adds to the stress of the awake patient. We try to keep the patient engaged, and we encourage them to ask questions during the procedure, and we have a continuous conversation. And they understand we do this every day, and this is all pretty routine for us. And like I said, I would say over 90% of our patients don't require any sedation, and they do just fine without it. We do occasionally put patients to sleep. The indication for that is, say, a young child with dystonia. We use general anesthesia for that. A patient who has a movement disorder that involves the head and neck that is problematic, we might put that patient to sleep. Or a patient who's very anxious. A patient with an anxiety disorder, sometimes it's just better to put that patient to sleep. So we can do the operation and get a good outcome with the patient asleep. We just think that we get a more reliably good outcome if we have the patient awake for our testing. Is it risky, DBS surgery? And I have a way of explaining the risk-benefit situation to our patients that involves 3 numbers. The numbers are 1, 50, and 90. We've studied our outcomes very carefully here. We've done over 2,000 DBS lead implantation procedures, and in our hands, using the methodology that I've described, where every patient gets a very careful risk-benefit analysis, and then we all come up with an optimized plan for that particular patient together. If we follow all of those protocols and we use our careful intraoperative methodology that I've described, then the 90 number is there is a greater than 90% chance that if we do all of that, if we ask you in 1 year, are you glad you did it, that your answer is going to be yes. Actually, what we specifically ask is, compared to prior to DBS surgery, are your symptoms much improved, very much improved, improved, the same, worse, much worse, or very much worse. And That's called a global outcome scale. We also ask that same question about compared to before, is your quality of life very much improved, etc. And we consider success if the answer to those two questions is very much improved or much improved, then that's success. Anything less than that we consider to be failure, because DBS doesn't cure Parkinson's disease. DBS doesn't save your life. DBS just alleviates symptoms, and the only reason to do it is to improve quality of life. So if we fail to significantly improve your quality of life and we put you through all of this stuff, then we have failed. So by that measure, we have a greater than 90% success rate using these methods that I've described, which, if you know anything about surgery, that's sort of a phenomenally excitingly high number that makes my job very fun. The 50 is the second number. I'm going to talk about that one last. 1 is the number that everybody wonders about, which is what is the likelihood, since this is brain surgery, that something bad is going to happen and I'm going to end up with an injury to my brain that leaves me with some new problem that's worse than the problem I came in with. In our hands, after about 2,000 operations, there are between 15 and 20 patients who had serious brain injuries from a hemorrhage or a stroke that left them much worse off than they were when they came in. So essentially the way I describe it is brain surgery, and there is 1 in 100 chance that you're going to sustain an injury to your brain and that you may wish you never met me. And that's another part of my job that is not fun. But so that's what you have to sign up for. 90% chance you're going to be glad you did it. 1% chance you're going to wish you never met me. Now, another interesting number is the 50. We did a study looking at adverse events, and we accepted all adverse events. Basically, anything that the patient said, I didn't like this. Now, they might have been an infection, a minor infection where we just give you some oral antibiotics for a week and it clears up, superficial, or a severe infection where you develop a horrible, infection under the, around the hardware. The only way we can get rid of the infection is to take the DBS hardware back out, put you on intravenous antibiotics for a few weeks, watch you for a few weeks after the antibiotics, and then repeat the procedures to put the DBS back in, which is, sort of a nightmare, as you might imagine. But that would be considered a serious adverse event requiring multiple surgical procedures to fix. Now, interestingly, even patients who have that sort of a serious adverse event, think about the numbers, 50% of the patients have an adverse event, but 90% of the patients, if you ask them a year after surgery, are you glad you did it, say yes. And amazingly, even patients who go through some of those serious adverse events still say, oh, I'm so glad I did that. My life is so much better than it was before DBS surgery. So that's fairly gratifying. I would submit that most complications of DBS surgery are self-limited and not severe. And we count basically anything. If you have DBS surgery and you say, oh, I had a headache for 3 days and nobody told me I was going to have a headache, we would consider that an adverse event. So they might be minor, they might be major, but half the patients reported some adverse event. And so going into it, that's a good way to understand the risk-benefit ratio. 90% chance you'll be glad you did it, 1% chance you'll hate me, and 50% chance there's going to be something along the way that you don't like. So I thought I'd throw that in because I think that's important. Question 4. If I have DBS surgery, will I be able to stop taking all these pills? That's a really good question. The short answer is most people after DBS surgery take less medication. However, the vast majority of people after DBS surgery still take medication. And I think it's important to keep in mind that the medications have beneficial effects. The deep brain stimulation has beneficial effects. They are not identical, and our primary objective, is not necessarily to have you not take any pills. That would be nice, but our primary objective is to make each patient the most highly functional person they can be. And in general, that's achieved with some combination of medication and stimulation. So the vast majority of people take less medicine, but they continue to take medicine in order to achieve the best possible functional capacity that they can achieve. Question 5. How long does DBS last? That question is actually more interesting than you might think. It sort of depends what you mean by how long does DBS last. DBS, well, the hardware is made out of metal and plastic, and it's going to last much longer than you are. It's going to be around long after you're gone. The battery in the pulse generator lasts typically 5 years or so and has to be replaced in order to keep the DBS functioning. So that's not what most people mean when they say how long does DBS last. What they mean is how long do the therapeutic benefits, the symptomatic relief, last after DBS surgery. And if you look on the internet and you search that question, a lot of people will say something like, 5 to 10 years. That's actually not true. The therapeutic benefits associated with deep brain stimulation, as best we can tell, last forever. Meaning, as long as you keep the battery functioning and delivering the stimulation to that pathologic circuitry in the brain, the DBS continues to provide benefit. However, as I mentioned earlier, DBS does not cure Parkinson's disease, and unfortunately, Parkinson's disease is a progressive degenerative disorder that gradually gets worse over time. And unfortunately, DBS, as best we can tell, doesn't really affect that gradual deterioration. So, here is how I explain that 5 to 10 year number that people throw out. If your ability to function, let's say, is way up here when you're 20, and like every other human being on the planet, your physical functioning gradually deteriorates over time. I feel it. I'm 55, and I can't function as well as I could when I was 20, physically. And if you have Parkinson's disease, then that physical deterioration actually speeds up a bit. And at some point, someone figures out you have Parkinson's disease and they put you on medication, and that helps. And then you keep deteriorating, and at some point, someone says, you should consider surgery. And if you're like most people, you say, there's no way I would ever do that, and you keep deteriorating. And then a couple of years later, when your quality of life is getting worse and worse, your ability to function is diminishing, and everyone's threshold is different, but it's very common at that point to say, tell me about that surgery thing again. Maybe I would consider it. Things are getting pretty bad. And then you come and you talk to us about surgery, and we joke about this all the time. The person who learned about the surgery and was actually recommended perhaps by their neurologist 3 years ago, who said absolutely not, never, now 3 years later, after discussing it, needs it right now. Not only do they want it, but they can't wait. They must have it now. that's a typical progression. But let's say this is where you are in terms of your ability to function before DBS surgery. And you have DBS surgery and it's very successful and it bumps you up to here. Well, that's great. But as time goes on, your ability to function even with DBS is going to gradually deteriorate just like every other person on the planet. And out here, maybe 5 or 10 years later, your ability to function may be as bad as it was before DBS surgery. So a person might have the tendency to say, well, the DBS isn't working anymore. But in answer to that, I ask the patient, well, try turning it off, because if you turn it off, you realize that you're here without it and here with it. So that 5 to 10 year number is you may go 10 years with improved functioning relative to where you are now, and 10 years later your functioning is as bad as it is today, but without the DBS, your ability to function is much lower. And I have patients that I operated on 20 years ago, and they still, if they're still alive, come in to have the battery replaced. Even those who are quite debilitated in terms of their physical functioning, because without it, they're even more miserable. So the short answer is the beneficial effects of DBS last, as best we can tell, as long as you do, but it doesn't cure Parkinson's disease. Question 6. I understand, Dr. Foote, that you've been doing DBS surgery for 20 years. How has the surgery and the technology changed over that time? That's a really interesting question. I would say I learned originally how to do deep brain stimulation surgery in France, in Grenoble, France, from a man named Professor Alim Louis Benabid. And he was essentially the guy who developed modern deep brain stimulation. And if he were to come to my operating room today and see the way I do the operation that he taught me to do 20 years ago, he would find it unrecognizable. We are constantly improving the way we do things. We're always looking for a better way to do it. We're always trying to develop new technology to get safer and better outcomes. And so it has evolved dramatically over time. I'll give you an example. Some of this may be a difference between practicing medicine in France and practicing medicine in the United States as well, but a typical DBS operation that we would do in Grenoble, when this is a long time ago, they don't do it exactly that way today either, but back then we would start a DBS operation around 9 a.m. and we would implant 2 DBS leads in one day in the same patient, and starting at 9 a.m., we would finish frequently after midnight. The patients were awake, and they participated usually with the first DBS lead implantation, but by the time we got around to doing the second side, the patients were so wiped out that they were incapable of participating. And they very commonly spent 2 or 3 weeks in the hospital recovering because the operation was such an ordeal for them. Interestingly, we would break for lunch, and we'd go and sit in the kitchen in the operating room and eat lunch while the patient was in the operating room waiting for us to come back. And we would, as French people do, we would eat our lunch and have a glass of wine, and then go back to the operating room and keep working. It's incredible to think of it today about how I learned to do this. In terms of technology, the targeting was based on X-rays and what's called ventriculography. So instead of high-resolution MRIs and CTs and the things that I've kind of described in our methodology today, we would inject dye or contrast, do a lumbar puncture, a spinal tap, inject contrast into the cerebrospinal fluid, the fluid that the brain and spinal cord flowed in, and we would move the patient all around to try to get the contrast into the head, and then we would take X-rays from the side and from the front, and the X-rays would show where the fluid goes, and the landmarks that we could see, we would match up to an atlas, and basically we would triangulate the target based on someone else's brain that had been carefully sliced up and measured, and our estimates of where these structures would be. It was called indirect targeting. So we'd go to the map and we'd go to the coordinates on the map and say that's where we want to be, and then on each patient, we would go to those coordinates and hope that there was consistency from brain to brain, and we had ways of trying to deal with variability from one person to another, but they were nothing like the ability we have today. Now we use direct targeting, and indirect targeting based on an atlas is, in my opinion, archaic and should never be used, although I will say there are centers that still use that technique. Direct targeting is you get imaging that's good enough that you can actually see the thing you're aiming at, and you don't have to guess where it is, and you aim at it, which sort of makes sense, I think, to most people intuitively. I'm going to add question number 7, because I just saw question 6 and 7 are kind of related. Question 7 is, what are the most exciting recent developments in DBS technology? Which is, of course, all part of this. I would say the most exciting recent developments are we call it smart DBS or adaptive DBS. Some people call it closed loop DBS. But our research team is heavily invested in closed loop DBS, which involves a pulse generator that is capable not only of delivering pulses of stimulation to the brain to alleviate symptoms, but it can also record the electrical activity from the brain continuously, and it can be programmed to respond to those signals that it's recording to the brain and change the stimulation parameters to match the needs of the patient on the fly. So instead of programming it to deliver stimulation a certain way and having it always be the same, these new DBS devices can continuously record the signals, and eventually what they will do is they will monitor the electrical signals in the pathologic circuit that we're trying to treat and deliver stimulation in response to those signals to optimize things. So we look for what's called a biomarker. It might be a pathologic biomarker. So we program the device to say, every time you see this abnormal signal, deliver more stimulation. And when that signal goes away, you can turn yourself off. You don't have to. And in that way, when the patient needs stimulation, they get the stimulation. But when they don't, the stimulator turns itself off, and there are no side effects, or there are fewer side effects from the stimulation. So, that's one of the ways that we envision most DBS will happen in the future, is that it will be smarter, and it will, because patients, for example, with Parkinson's disease, as you well know, your symptoms fluctuate throughout the day. They're not always the same, and so it stands to reason that the stimulation ought to be variable as your symptoms vary. So we're excited about that, and we're working on implementing those sorts of solutions. So far, we haven't, in Parkinson's disease, programmed the device to, well, in limited ways we have, but it's not ready for prime time for global use. but eventually we'll get there. We do use those continuous recordings to help us optimize the programming, even if we leave the programming the same. Recording from the electrodes can help us determine which of the electrodes in the brain will produce the most benefit and or which will cause the most adverse effects. And so we can more optimally program when we have these continuous recordings from the brain while the patient is behaving at home. So that's a very exciting technological advance. Directional leads or current steering, instead of cylindrical DBS contacts in the brain where you send pulses of electricity and you can increase or decrease the energy, and the more energy you put in, it spreads current like this. And let's say this part of the brain, if you stimulate it around the DBS lead, it results in alleviation of a patient's tremor. But if you turn it up, and the more you turn it up, the better the tremor suppression. But eventually, if you turn it up too high, it spreads into this structure over here, which causes slurred speech, for example. Well, with a current steering or with directional lead, we can stimulate more over here and turn off part of the stimulation that's going that direction. So we can steer the current into the therapeutically beneficial area and away from this area that causes an adverse effect. So we think that those steerable or directional DBS leads are going to improve the outcomes of DBS surgery by increasing the therapeutic window. Other developments in DBS technology, there are a lot of developments in both targeting software and imaging that are improving our ability to see what we're aiming at and to get there effectively without hurting people. I would say that DBS surgery is dramatically safer today than it was 20 years ago. The likelihood of something bad happening is much lower, and the likelihood of you being happy with the outcome is also much higher. So we've gotten better at it over the years. Yikes. There were a couple more questions, but I just realized that I've exceeded my allotted 60 minutes. So I think this is a reasonable place to stop. I hope that you found this interesting. I enjoyed it. And thanks again for having me.
Thank you, Dr. Foote. If you'd like to watch it again, just visit parkinsonplace.org. And now, why don't we hear from one of our very active members? This is Roger Tregelis.
My wife found this place. We came and visited. We fell in love with the staff, the programs, and we moved here. And ever since, I've been an active member, both before the pandemic and after on Zoom. I've learned a lot of things about exercise that I didn't know before. For one, I learned about being creative. If you had told me that I would like dance 4 years ago, I would have said you're crazy. Now the dance exercise classes, they're my favorite. They're the thing I enjoy the most because I get to be expressive, I get to be creative. Even my wife says, where does that come from?
Roger takes full advantage of all our virtual classes, including Rocksteady Boxing, taught by Manny Arce.
Hi, I'm Manny Arce. Welcome to Parkinson Place, and this is Rocksteady Boxing. So today we're going to go over some boxing technique. We're initially going to start with some dumbbells. 2 to 3 pounds is the usual weight that everybody uses. And make sure you have some water close to you, and we're about to start. All right? So the first things first, you want to get into your fighting stance. Always remember that if you're right-handed, you want your right foot to be back. If you're left-handed, you want your left foot to be backwards. All right? Since I'm right-handed, I'll stand right here. You're going to keep your elbows in, hands in, and your chin pretty much tucked in so you can protect yourself, all right? First things first, we're going to work off the jab. That is your lead hand. You determine that by your lead foot. We're going to throw it all the way straight out, and then you're going to bring it back in, all right? So again, you're going to bring it out and then all the way in. Make sure that the hand that you're not using, which in this case is my right hand, it stays up by your cheek, just like this. So make sure you get that full extension all the way, everybody. Good. Now notice that I'm stepping forward a little bit. That is where the power is generated from the jab. You want to take a little slight step forward and then bring that hand back in, okay? So that is the jab, everyone. The second punch that I'm going to teach you today is going to be the cross, which is coming off from your back hand. And all you're going to do is pivot with your back foot, shift your waist forward, and then throw it straight ahead. All right, so again, you're just going to pivot and throw it straight ahead, everyone. Just like that. Now, a good way to memorize this is pretend like you're squishing a bug in the ground, okay? So every time you pivot on that back foot, you kind of bend the knees down, make sure that you squeeze all the way down. So you're squishing that bug, all right? Make sure you go all the way down and extend that arm all the way. You want as much range of motion as you can, okay? As much as your body allows you, so make sure you get that full extension all the way. Very good, everybody. Now bring those hands back up, very important. Keep your hands up all the way by your chin, good. Now we're gonna put both together. You're gonna throw the jab and then the cross. Okay, so the jab and then the cross. Jab and then the cross, right there. Jab and then the cross. Don't forget to bring that knee down as well when you throw that cross to apply that power as much as you can. Good. Jab, cross. Jab, cross. Good. Let's do about 5 more of those. Get that full extension, everyone. Make sure you bring that punch all the way out. Good. There you go. 2 more. Excellent. And there we go, everybody. Good.
Join Manny and other Parkinson Place members in Rocksteady Boxing a couple of times a week. Just go to parkinsonplace.org and join. It's free. We'll send you links to all of the other classes. Our next presenter is Dr. Angela Roberts. Dr. Roberts is an assistant professor at Northwestern University's Pepper Department of Communication Sciences and Disorders. Dr. Roberts is a trained speech-language pathologist with more than 20 years' experience in neurodegenerative disorders. Welcome, Dr. Angela Roberts.
Good morning, everyone at Parkinson's Place. I'm so happy to be with you today. I'm joining you from my office in Evanston, Illinois at Northwestern University. And today we'll have a few minutes together to really think about meaningful connections, tips and strategies for dealing with communication challenges in Parkinson's disease. These are my disclosures. A few learning objectives that I hope that we can accomplish today. The first is to really focus on the importance of communication, not just as a way of getting messages across, but as a form of connecting for persons with Parkinson's disease and their care partners. The second objective is to really explore deeply how Parkinson's disease affects conversation and social communication in Parkinson's disease. And the third is to focus on strategies for how we can create and maintain connections through effective communication. So starting with a few definitions here. Communication, or what I'll be talking about a lot today, which is conversation, is an exchange or interaction between 2 or more people. It's not only a tool that we use to convey information back and forth, importantly, it's a tool that we use to establish and maintain relationships with one another. And when it fails, it can affect quality of life, it can increase caregiver burden, and it can make everyday activities really challenging. So continuing to kind of expand some of these topics that we'll be talking about today, I want to visit this concept of transactional versus interactional communication. So we need both in our lives. And transactional communication are those types of communication events where we're trying to get a message across, trying to get something done, making sure your partner takes out the garbage, ensuring that the kids don't forget their lunch or their backpack. So these are the everyday, just kind of quick message exchanges that we do. But there's another form of communication here that's important, which is interactional. Interactional communication are the moments in our day, the communication events that we use to connect with other people. These moments can be by touch, they can include words, they may just be an exchange of eye glances, but they're those moments where we use our entire body as well as our language system to connect with another person in our life. So we have this balance of transactional and interactional communication. One of the things that happens in the context of chronic diseases such as Parkinson's disease that people live with for a very long time is that they and the people around them become overly dependent on these transactional communication moments. Conversations get harder. It's more challenging to connect with another person. The burdens of helping to support care can be overwhelming. And when conversation or communication switches and loses this balance, when it becomes more transactional and it loses its balance between transactional and interactional communication, this is where we really see the issues emerge relative to increases in caregiver burden and losses in quality of life and social isolation for the person with Parkinson's disease. So a lot of what we're going to be talking about today is skills and tips for how to maintain this balance in communication and to reduce the effort and load associated with having conversations. So another point here is that communication can be both verbal and nonverbal. We're going to be talking a little bit today about both kinds of communication. Effective conversations also require us to be able to take our partner's perspective. In a way, we're all mind readers. When you're in a conversation with someone or in a social exchange, you actually know 3 or 4 words ahead, sometimes even as much as a sentence ahead, what that person is going to say before they say it. The more in tune we are with our partners, the more able the skill is. And this is an important one because one of the things that we see that can change in Parkinson's disease is some of this loss of theory of mind or some of this loss of ability to take the perspective of another person. And that can have devastating impacts on conversation and communication. One of the other skills that's incredibly important is this ability to coordinate across speakers and topics and ideas and turn-taking exchanges. And we're going to talk about the ways that Parkinson's disease affects this as well. In short, the key components of living with Parkinson's disease and being a care partner to someone with Parkinson's disease can impact many of the skills and abilities and natural exchanges that we have in this kind of conversation and communication space. So we communicate with our whole body. I'm a whole body talker, but all of us actually communicate with our whole body. We read facial expressions from people's eyes. We listen to the words and not just the words that they say, but the pitch and the flow of their voice, the loudness of their voice to help us understand their emotions. We know that someone's excited when they increase the rate of their speech and increase its loudness. We also know that someone is sad when we see the expression on their face and a slowing of their voice and a quieting of their voice. We use our hands to communicate and to emphasize points, but we also use our hands and our body in touch to have interactional exchanges with others. And speech is certainly a key part of how we communicate. But one of the challenges with Parkinson's disease is that both the motor symptoms and the non-motor symptoms can lead to what we call a social communication impairment. In fact, this is the communication impairment in Parkinson's disease that perhaps we talk the least about. But we have this kind of growing awareness that as many as 30% of people with Parkinson's disease may really have an impairment in both social cognition, social engagement, and social communication that exists beyond just the speech system. And this may occur very early in the diagnosis because aspects of motor symptoms, as well as the non-motor symptoms, contribute to this problem. So things like reduced facial expression and vocal expression, we're going to talk about these in a bit more detail. Reduced body language, so difficulty spontaneously initiating gestures that reinforce your message or communicate a message. Having lower speech clarity or a hoarse or quiet voice, these theory of mind changes that I talked about that keep you from adequately reading your partner's perspective. The ability to respond quickly is affected in Parkinson's disease. And all of these things contribute to this larger kind of recognized cluster of symptoms that move beyond speech issues and into these more social communication challenges. So in a recent review paper that was written by Pringer and colleagues, a Canadian group, they do a wonderful job of laying out these changes in social communication, social aspects of cognition. And they also highlight three really important points and we have literature in Parkinson's disease to suggest this, which is some of these early changes in facial expression, speech and communication, difficulty making oneself understood, some of these components of social cognition, such as reading the perceptions of others. These can all contribute to a social connection problem in persons with Parkinson's disease. And so they identify three areas where this is really problematic. The first is stigma, or this notion that the way one presents themselves, the way they communicate is actually isolating them from, it's taking away a sense of their personhood in society. Dehumanization is another component of these kind of social communication impairments, that it can cause someone to see another person as being less than human or not recognizing their humanhood. One of the things this article points out is this can be particularly problematic in medical and physician exchanges, where the person with Parkinson's disease, because of their communication challenges, may not be as involved, as engaged, or as incorporated in their care. The third point that they highlight is one that we do some of in our research as well, which is the impact on these communication changes on withdrawing, social isolation, and loneliness. This third one is important because loneliness is associated with an increased risk for dementia. This has been shown time and time again. So social isolation is your actual isolation from others. Loneliness is your perception that isolation is making you less connected to others than you would like to be. And this loneliness component is really where we see the increased risk for dementia. Loneliness and its impact on the risk of dementia is independent of social isolation. It appears to be independent of depression. And it's not just the person with Parkinson's disease who's at risk, it's also their care partners. The Family Caregiver Alliance has looked at care partners, and about 44% of all care partners experience at least a moderate degree of sense of loneliness. And so since Parkinson's disease comes with an increased risk of cognitive impairment and an increased risk for dementia, then one of the things we certainly want to do here is mitigate those risks as much as we can. And so addressing and working with and improving these kind of social connections through better conversations, more effective engagements with others is not only important from a quality of life perspective, but may help reduce some of the risk for dementia. I'm going to talk about a few of the symptoms that occur in Parkinson's disease, and then we're going to talk about some helpful hints that may aid people as they're living with some of these changes. We can't always do an absolute curing of some of these symptoms. In fact, levodopa or some of the dopaminergic medications that we use in Parkinson's disease may not help these symptoms as much as it does the physical motor symptoms. And in some cases may actually contribute to these changes or some of the problems that people see. But we can compensate. And we do know that there are behavioral therapies that can help. So one of the first ones I want to talk about is this kind of notion of facial masking, or what sometimes is called hypomimia. And facial masking is the reduced ability to spontaneously generate facial expressions. It's often thought to emerge from some of the rigidity or stiffness and slowness in the muscles that occur in Parkinson's disease. But we also think it might come from a true emotional state issue, that part of the problem is not just reduced motor movement of the facial muscles, but is actually a reduced ability to mimic the expressions of others in context. So we all do this as human communicators. I watch you smile and then I smile. I see that you're upset and I change my facial expressions in response. Part of what we think Parkinson's disease, although it's not as well understood, may be doing here is actually affecting a person's ability to read their partner's expressions, not just physically read them, but emotionally read them from the perspective of being able to adjust their own. One of the common concerns for people with Parkinson's disease, and again, this is a known kind of consequence of some of the muscle and motor issues in Parkinson's disease, is that their smiles can be less realistic, less natural looking. And this may actually cause others to view the person with Parkinson's disease as being more withdrawn or cold or disinterested, none of which are true, but it can certainly lead to misperceptions. People with Parkinson's disease can have difficulty modulating their facial expressions. in conversation and in context. That's what I was talking about just a minute ago with this kind of hypomania piece. So oftentimes what they're thinking does not match their facial expressions, and the context does not match their facial expressions. And so this can, in conversational context, can actually disrupt this kind of automatic empathy and pleasure response in a communication partner that's driven by observing a person smile or observing their facial expressions. So this is more than just a motor problem, right? This kind of notion of having difficulty modulating one's facial expressions can be really problematic, not just in terms of getting messages out, but also in how others respond to the person with Parkinson's disease. And so with this, it's really important for us to remember, it's incredibly important for us to remember that this does not affect the ability to feel emotions. It simply affects the ability to convey emotions. So it's not just the ability to convey emotions that can be affected in conversations in people with Parkinson's disease. People with Parkinson's disease can also have challenges processing emotions. So we have a little bit of work in this area where we're trying to understand if it's not just a motor problem, right? So my motor abilities won't affect my ability to potentially read someone else's emotions, but we see that emotional processing is affected, not in everyone with Parkinson's disease, but with some people who have Parkinson's disease. More recent research suggests that dopamine therapies or levodopa may actually affect emotional processing. And we can see that people are better in their on state and they're worse in the off state of their medication. So this suggests that levodopa in some cases may be helpful for the reading of emotions. And there's a little bit of research that thinks that this kind of motor issue with patterning emotions in other people, so my ability to read and modulate my emotions based on your expressions, might actually drive some of the emotional processing deficits as well. So if I can't generate the emotion, if I can't generate the motor movements that go with the emotion, then it may give me additional difficulties processing that emotion in others. We know this isn't just in facial expressions. The difficulty reading emotional cues also comes in the voice information. So again, I'm happy because my voice is light. I'm sad because my voice is heavy. And people with Parkinson's disease have shown some challenges, not just in reading facial expressions, but also in reading the vocal cues that go with emotions. So some of the research that's been done actually helps us come up with ideas that may be helpful here. So as I said, levodopa may help in some cases with this emotional processing issue. It doesn't necessarily help dramatically with the facial expression problems that people have. But there is a little bit of evidence that tells us that people with Parkinson's disease do better when people express themselves through multiple channels. And what do I mean by that? It means that emotional expression may actually be improved. The ability to understand emotions as expressed by others can actually be improved if you say the words that go with how you feel, if you really exaggerate your facial expressions, if you use body language to go with those words, and if you animate your face and your eyes so that that message is really clear. So if you're a communication partner of someone with Parkinson's disease and you feel as if they're not always understanding you or understanding your emotions, then maybe one of the things that you can try is actually adding more channels, adding body language, using and saying explicitly the words that you feel, and also animating your face more. But this is also true for the person with Parkinson's disease. Thinking about the fact that your smile may not be exactly the way it was before, or your eyes may not be as expressive on all occasions, or your facial responses may not be quite matching the message that you intend to send, you too can support others by intentionally making your body larger, by acting out and really adding gestures to what you have to say, by ensuring that you are saying to someone, I am happy today, even if your facial expressions don't convey that. So we can't depend always, in the case of Parkinson's disease, on someone being able to read our expressions completely. We have to add the words that go with those expressions, and we have to layer these multiple channels of ways of conveying expressions throughout the entire body in order to make that messaging clear. So some of these helpful tips are the ones that I just laid out for you. So communicate with your whole body. Say and show what you mean, and state your feelings and emotions explicitly. Some treatments, like the Lee Silverman voice treatment, have actually been shown to help with facial expressions and to help with this animation of vocal expression. And so while it's not necessarily the direct target of those interventions, they can help. And for care partners, as I was saying a few minutes ago, if you're uncertain about the emotion that the person with Parkinson's disease is trying to convey, just ask. Don't assume. And it's important that we kind of learn this kind of lesson of valuing communication through all channels. The facial expressions are not the only change in communication that affect people with Parkinson's disease. So persons with Parkinson's disease can have a quieter voice. They can tend to produce fewer words per minute. They can have difficulty retrieving words. They may get stuck on a word. It may take them longer to come up with a word. They may pause more frequently when talking, and they may do so in places that don't exactly make sense in a sentence. And that can be challenging when pauses occur in places and sentences where they're not supposed to. That makes it harder for a conversation partner to follow the conversation. We can see an increase in grammar error. So people with Parkinson's disease may use the wrong tense to mark present tense versus past tense. They may not always have the correct plural marker on a verb. And so this can create challenges in making sure that the message flows clearly. They can produce less information and omit key ideas. And so it may be that they're having a conversation with you and you're just sensing that there's this real gap there because it just feels like something is missing, that there's an idea that was missing that they intended to convey. And this indeed does happen even early on in the disease. And there could be more challenges with speech fluency. So this need to revise what they're saying, repeat words, repeat sounds. And so all of these things can disrupt the natural flow of conversation and communication. In fact, about 80 to 90% of all people with Parkinson's disease will experience some changes in their speech and voice at some point in time over the duration of the disease. And about 30% of all newly diagnosed cases may already have some changes in cognition, not dementia per se or mild cognitive impairment, but some changes in cognition that may affect the language system. So I'll touch here briefly on how we address some of the speech and voice issues, but then I really want to spend the majority of our time today talking about more of these communication and language-based challenges. We've had speech treatments in Parkinson's disease for a long time, and the majority of these treatments focus on increased loudness and voice effort. Most famous of these, and the one that has the most evidence, is the Lee Silverman voice treatment method. It's a highly structured intensive exercise program. It's systematic, and the goal of the Lee Silverman voice treatment program is to help to recalibrate the level of loudness that is needed to be clear in communication and the amount of perceived effort that's required to produce that loudness. So people with Parkinson's disease often think that they're being loud enough or that they're producing enough effort, but the disease itself dampens that effort and dampens the loudness. And so Lee Silverman helps people to recalibrate the amount of effort that's needed to have a loud enough voice. So there are other voice treatments that have come online in recent years that focus on loudness and voice effort and do so in a variety of communication contexts. But still to date, this program has the most evidence behind it in terms of really showing change and differences in people with Parkinson's disease. It doesn't mean that the other programs don't work or they're not helpful. You may be engaged in other kind of exercise programs for voice. They all may have aspects of benefit. This is just the one that has been shown over the years to have at least the largest of those benefits. Other techniques that are commonly used in this space include singing or vocal and choral exercises. So singing in a choir or actually doing singing therapy as a part of Parkinson's disease. And so people have also looked at these from a science standpoint. In general, they help to improve your breath support for speech. And they can help to reduce the fatigue that you might feel having a long conversation, but they really give limited improvements in voice quality. So the voice may still remain a little bit flat. You may still have hoarseness, some pitch flatness in terms of not having as much variability in your voice, But in terms of supporting your breath volume for speech, these do seem to be relatively effective. Kind of a third approach that's used in the Parkinson's disease treatment space for speech problems are instruments or devices that we can use to help with speech. And this is one of those, a device called the Speech 5. It's worn like a hearing aid. You don't wear it all the time, but you wear it while you're doing therapy, and you wear it when you need your voice to be louder. And so one of the things that it does is if your voice isn't loud enough, it plays this kind of multi-talker babble. It sounds like multiple people talking, like a cocktail party noise. What that does is optimize an automated reflex called the lumbar reflex. So when that noise is played in your ear, people immediately lift their voice up to be louder than that noise. And so without even having to think about it or generate substantial effort, your voice lifts above the noise and you are louder. And so this device is used in a practice component, actually as a therapy, where people wear the device several hours a day and practice talking as a way of increasing their muscle strength and increasing the effort that they are able to produce for clear speech. And then the device can also be used as compensatory in some environments if you're worried that your voice is not going to be loud enough. But this is kind of one of the newer treatments. Again, it has less evidence perhaps than Speech 5, but the evidence that is coming out is quite strong in favor that this approach works. Perhaps particularly well for people with Parkinson's disease who have cognitive impairment, for whom thinking about being loud and producing increased effort may be more challenging. So we have this kind of converging evidence, both from human research and animal research, that tells us from a speech perspective and a voice perspective, if we train specific muscle groups and we train them intensely, people do get better. And some of the animal model work on voice therapies in Parkinson's disease tell us that the earlier we put these treatments in place, the better long-term outcomes we may have. And work that's been done in coordination with the Lee Silverman voice treatment protocol has actually shown that intensive loudness training can actually change brain activity toward more normal patterns for voice and speech. So it takes the kind of abnormal patterns that we see in Parkinson's disease and makes them look a little more normal. So it suggests that these treatments are not only changing the behavior, they're not only able to make you louder and perhaps even change your ability to modulate facial expressions and to have more range in facial expressions, but importantly, they actually change the underlying neural patterns or how the brain is working when you're talking. One of the things I want to point out, and where we're going to spend the rest of our time together today, is that in our research, and we've done quite a bit of this research where we follow people into their homes and we analyze their conversations, so people with Parkinson's disease and their care partners, because we really do want to try and understand what are the nature of the breakdowns that matter. So by conversation breakdowns, we mean those moments in everyday interactions where you say something to your partner and it just doesn't go through. So they may not have heard you, your message may not have been clear, and it ends in a huh, a what, I didn't understand you. Or worse yet, it ends in one of the partners walking away from the conversation. So we spend a lot of time trying to understand these, because it's important for us to think, is it just the voice problems or the speech problems or the facial expression problems that contribute to these social communication challenges in people with Parkinson's disease? And indeed, we find that's not the case. In fact, about 2/3 of all breakdowns that we see in these conversations are completely unrelated to speech and voice clarity. So I think treating voice and speech is spectacular, and it is a much needed treatment target in people with Parkinson's disease. But when we look at what's actually affecting conversations in real world environments, we find it's much, much more than just the speech and voice issues. So even if we optimally treat speech and voice, we may not be addressing all of the challenges that people with Parkinson's disease have, engaging with their care partners, their friends, their family members, and others in their everyday lives. And so some of these challenges I've kind of alluded to throughout the talk today, but I'll highlight some of the ones that stand out most from our research. Is that one of the things that really causes challenges in these Parkinson's disease conversations are these abnormally long pauses. They create confusion. And so this happens when you may say something to the person with Parkinson's disease, and it takes them longer to either process what you've said and also to formulate what they want to say and to get the message started. And so these long pauses actually tell the other person, hey, they may not be interested in talking to me, or hey, they're not going to take up their conversation turn. And so the person just continues to talk. And then what happens is, by the time the person with Parkinson's disease has planned what they want to say, and they've pulled together how they want to say it, the conversation has completely moved on without them. So these long pauses are one of the first things that we see that disrupts conversation and turn taking in Parkinson's disease. Unclear topic shift, so people will start a topic and shift off to another topic and shift to another topic without finishing a theme or a line of thinking, and this creates real challenges as well. I already talked about these kind of slow processing and delays in initiating what you want to say. And indeed, those unclear verbal signals that we talked about at the beginning, this kind of hypomania and difficulty reading expressions, as well as difficulty conveying emotions, these contribute to a lot of the conversation challenges that we see. But one of the things that I want to point out here is that these problems are not all about the person with Parkinson's disease. In fact, when we are looking at these breakdowns, while 2/3 of them are caused by things unrelated to speech clarity and voice issues, they're not all caused by the person with Parkinson's disease. In fact, for some of these sources of breakdowns, we actually see that the care partner is the cause. One of the more curious things that we've been spending some time trying to understand is the fact that the longer people tend to live together with Parkinson's disease in their life, the more conversation partners also learn bad habits around communicating. They abandon the attempt to try to understand what the person with Parkinson's disease is saying. They give up too easily. They fill in information without allowing the person with Parkinson's disease to have an opportunity to say what they'd like to say. And they also rush and add added pressures in the context of conversation that actually lead to some of these breakdowns. This is not about a blame game, right? When we're talking about interactional communication, when we're talking about the need to connect with another person, language and the exchange of information and the exchange of emotions and the exchange of connection happens in the middle of two people. More people if it's a larger conversation, but at least two people. So this is not about assigning blame, but it is about everybody taking responsibility. The person with Parkinson's disease, as well as their care partners, as well as anyone else who's in the conversation circle, to try to support the person with Parkinson's disease in being their best in that conversation moment. They can't change the fact that they have Parkinson's disease. And as I've already talked about today, while there are some treatments that help here, not all of these symptoms are going to be addressed by medications or by traditional speech and voice therapies. So some of what we have to do here is actually offer some empathy, understand the problem, and address it through another lens. I'm going to talk about that for the next few minutes. Here's an example of what I mean by some of these language trouble sources. So this is how we annotate and break these things down in our lab when we're kind of documenting these conversations. So this is one turn exchange between a person with Parkinson's disease, noted here as PD, and their communication partner, noted here as CP. So they're having lunch, and this is a conversation that they're engaged in. And the person with Parkinson's disease says, he's told Ben not down quite. Care partner clearly shakes her head and says, huh? And the person with Parkinson's disease tries again. The screw, he was told he could bend and make the screw will come out. And the care partner pauses, clearly trying to process what was just said. And she responds, they're going to take him out? The person with Parkinson's disease gets another run at this. No, they could come out if you put too much weight on it. And then the care partner says, huh, got it, right? Mm-hmm. Oh yeah, they'll fail. So this comment about the screw, putting too much weight on the screw and the screw might break or it might bend or it might come out, took 3 tries, 3 back and forths between the person with Parkinson's disease and their care partner to get right. This was not an issue of speech clarity. The words were completely understandable. This was not an issue of voice volume. The voice was completely loud, but this was an issue of what we call one of these language trouble sources, where the person with Parkinson's disease very well knew what they wanted to say, but getting the words out right, getting the words out as they intended to do, fell apart. And it took multiple tries for them to get this across. This is what we call a successful repair. There was a breakdown, and they worked together to make the repair. But in the same couple that we watched over 3 days in their interactions, about 70% of the time, she actually would turn to the camera, roll her eyes, and walk away. Not because she's a bad person. She's not a bad person at all. She's a lovely woman, but because she's so frustrated by this being her conversation pattern on an everyday basis. Let's talk about maybe some of the things that we can do here to ease the burden when, as will always be the case, not all of the time, but on occasion, these types of challenges will emerge. I want to also point out that this gentleman did not have dementia. He actually had typically normal cognition. He just had Parkinson's disease, and Parkinson's disease affected his ability to get out what he wanted to say clearly. So one of the principles that we use when designing interventions in my lab for people with Parkinson's disease and their family members is this older theory, but one that is incredibly relevant. And so this is a theory from Kitwood. It was originally designed in aging and designed for dementia. It has great relevance, though, in Parkinson's disease as well, which is this notion of a positive care interaction. And key to maintaining a positive care interaction is to preserve personhood. Now, personhood means that we're not stigmatizing the person, we're not dehumanizing the person, and we're not isolating the person. In fact, all that we're doing is, and in every action that we undertake, is trying to optimize that person's sense of identity. It's exactly counter to what we see is happening in some of these social communication impairments, where the person with Parkinson's disease becomes stigmatized, dehumanized, and isolated. It's the exact opposite of that. So if we're going to optimize communication, if we're going to put any of these strategies into place, what we have to do first is protect and preserve personhood. So let me walk you through some of these, and I'll tell you how we kind of implement some of these strategies in our work. The first is recognition. So making sure that we recognize that person as having their identity. Part of that identity is Parkinson's disease, but the majority of that identity is not Parkinson's disease. It is a person who loves to fish. It is a person who was an attorney. It was a person who may be a father, a mother, a friend. It's about maintaining and ensuring that when we engage with someone, we recognize all of the person that they are beyond the existence of Parkinson's disease. We're not making Parkinson's disease go away. It's a part of the identity, but we're not making it the central part of someone's identity. Negotiation and validation. So these are really important techniques. No matter what strategies that I'm going to teach you today, it is important to always negotiate those with the person who has Parkinson's disease, that you're consulting them about their preferences, their choices, what their needs are, how they want communication strategies implemented. In fact, how they want other strategies implemented. This notion of validation, the acceptance of being connected to another person and acknowledging someone's feelings. We talked about how challenging this can be in PD, how challenging it can be for the person with Parkinson's disease to recognize emotions, but also how challenging it can be for you to understand what their emotions are. And that's why we go back to some of those earlier strategies of actually asking explicitly, what are you feeling? This is what I'm feeling, using words and not just facial expressions. Collaborating. This is about communication always being a collaboration. The problem is not Parkinson's disease, and the problem in isolation is not the person with Parkinson's disease. The problem is the collaboration between two people and the need to collaborate to work through these conversation breakdowns when they occur. And then this kind of principle of facilitation. Our job, all of us who live in the lives of people with Parkinson's disease, is to enable them to the best of our ability to accomplish everything that he or she or they would want to do otherwise. We build the ramps that allow them to have their best life. And in return, they are our partners as care partners and friends and family members of people with Parkinson's disease. They are our partners in helping us to live our best life as their partners in this disease. So it is a mutual collaborative act. But whenever you're thinking about communication breaking down or having difficulty understanding someone, remember, the problem is not for them to change. Interventions, yes. Therapies, yes. But the problem is not just to change the behavior. The problem is also to change our behavior and our ability to facilitate and help to reveal and acknowledge their expertise. So I want to talk about that here a little bit. Part of revealing competence, right? Part of what we think about in revealing competence and making sure that someone can be their best version of themselves is to actually acknowledge that these conversation difficulties occur in the first place. So when someone is having a hard time, say, gosh, I can really see that talking is tough for you today. Is there another way that you want to communicate? Or do you want to talk about this later? Would that help you feel better if you could get past your medication dose and you might feel better for us to have this conversation? But you also want to acknowledge your successes, right? You want to ensure that at every opportunity, you are recognizing the expertise and perspective that the person with Parkinson's disease brings, particularly of their own communication challenges. And then we're asking them what works for them. What would you rather I do differently? And we want to validate, we want to acknowledge and validate that when changes occur, those are tough. And when conversation breakdowns occur, those are difficult. And for people with Parkinson's disease, it is equally important that you validate your care partners, that you say to them, gosh, I know my words are not clear today, or I know that did not come out the way I wanted to, or I know that I'm not expressing myself the way that I would like to. That must be hard for you. What can I do to make it easier? This is the collaboration piece. It's about both partners, all partners working together to reveal their individual competence and to validate their perspectives as communicating socially connected beings. Let's talk about some pragmatic strategies. So how can you, with the mindset and spirit of acknowledging, validating, and staying connected to another person, now that you've got the right mindset, what tools do we actually use to just help the mechanics of the conversation run better? And I'm going to talk about a few of those as I wrap up my talk. So first, you want to set up for success. Optimize lighting, right? So if you're sitting in the dark, people with Parkinson's need to be able to hear and see. If you are talking to someone with Parkinson's, you need to be able to hear what they're saying, but also see their facial movements and their mouth movements to help, remember, add those extra layers of channels of communication, to add the body language, to add the facial expressions, to add the mouth movements. You can't do that in a dark space. So optimizing lighting, reducing distractions, making sure that you're sitting in front of someone for conversations about 4 to 6 feet apart versus sitting beside or behind. If you wear glasses or hearing aids, make sure that you have those on. And importantly, choose times of day carefully. People with Parkinson's disease have good times of day and bad times of day. They might be more vocally fatigued at some time of the day than another. They might not have the cognitive effort to have a detailed or in-depth conversation at one time of the day versus another. So always kind of check in. You know, we've got to have a tough conversation about having the roof repaired. What time of day would you like to have that? And honor that place, honor the place of them being able to choose the time of day where they think they will be best. You want to be present. You want to avoid demands that make you feel rushed or impatient. Sometimes that means holding off the conversation for a little bit later on. And you want to adjust and let go of your expectations around quality, accuracy, and quantity. Remember the first principle we talked about, transactional versus interactional communication. In interactional communication, to balance that interactional side, we cannot always be worried about quality, accuracy, and quantity. We sometimes just have to accept the communication as it is and acknowledge that we're both doing our best in that moment. let go of some of the expectations, and it will help to reduce some of the stress in these difficult communication breakdowns and conversation challenges. You want to provide extra time and present information in smaller chunks. So we talked about earlier that Parkinson's disease can, for some people, make real challenges processing information quickly or processing a lot of information at one time. This doesn't mean that you're reducing language down to a child level, but it means that you're presenting information in chunks, you're checking in to make sure that the person's understood, and then you're presenting more information. And you're watching for any cues, that body language or someone's overt comment, or maybe they're looking away as an indication that they're having trouble processing information. And you want to check in and say, did I make myself clear? Did you understand what I was saying, or do you need me to go back over that? Right? So doing these little check-ins can really help to pace the conversation in a way that helps someone to keep up with the pace of it without falling behind in this kind of processing lag that we know can happen in PD. I said earlier that one of the real challenges in conversation exchanges with people who have Parkinson's disease and their care partners, that we see people jumping around from topic to topic. And this is an area where the care partners are actually worse than the person with Parkinson's disease. We have seen this time and time again in our research. So the care partner will start a topic, jump to another topic, jump to another topic. Now, part of that is because they're not getting the same emotional facial feedback that's essential in a conversation to let you know that someone's following you. So we know that's part of that interactional problem. But for the person with Parkinson's disease who needs additional time to process information, these quick jumps can make it really challenging for them. So finishing a topic all the way through, being mindful when you're changing topics, and giving a cue, hey, I'm going to transition topics here now, or hey, I'm going to change topics. I know that might be challenging. Are you okay if I do that? Right? So really checking in to make clear some of these topic changes. Here I've identified a few things that can be extra helpful on video calls. So having a pen and a Sharpie close, so that you can actually not just tell people that you need more help, but you can write down, can you slow down? I cannot hear you. I did not understand you. So little index cards and a black Sharpie, particularly for virtual conversations with physicians, nurses, friends, and family members, can be really helpful. So conversation breakdowns, as I've already said, are already going to occur. They are just, we have them in my household. My husband has a hearing loss. They happen to us all the time. We want to minimize these breakdowns, but most importantly, when a breakdown occurs, we want to repair it. Remember I showed you that sequence about the screw? That couple worked really hard to repair that breakdown in that moment. And there are some skills to being able to do this. So one of the things that you can do is monitor signals for conversation breakdown. We know that these are not as overt in people with Parkinson's disease, but you can still watch for things like, a quizzical facial expression, someone looking away, maybe someone's looking down because they're not completely following the conversation. You can look for slowness in response time. So all of a sudden, the person was going back and forth with you pretty quickly, but now they've started to slow down. You can also ask directly for help. So you monitor those nonverbal signals, but actually say, I don't think I understood you correctly. Can you repeat that again? Did you mean to say? And this works both ways. The person with Parkinson's disease can ask their partner to clarify, but the partner should also say, I don't think I got that. This is what I understood. Is that correct? It is much better to ask for that repair directly than to just assume that everyone's understanding what's going on in the conversation and allow it to move forward to the point where the person with Parkinson's disease may become lost. Other things you do, you can repeat what you've said. So if someone asks you, can you repeat that? Just repeat, simplify it if you need to, but don't drastically change the message. You can rephrase and add new information. You can both gesture and show what you mean. You can use pictures and objects or even write a word down. This is what I meant to say. That can be more challenging in Parkinson's disease because of some of the writing problems, but may be helpful for you as a care partner to say, I know you're not following me. Here's the word that I'm trying to get you to understand, right? And so in more severe cases or when cognitive impairment comes into play, sometimes writing can be quite effective. Most of all, you want to stay calm and you want to avoid being critical. So what not to do Don't raise your voice. So one of the things that happens is someone says to us, what, huh? We all of a sudden assume that people must have a hearing loss, and we raise our voice. And when you raise your voice, it makes you scowl, it scrunches up your face. And then that adds to this problem of emotional processing issues. Because if I've raised my voice and I've scrunched up my face, now my partner thinks I'm angry at him or her, and I'm not. So keep your voice calm. When you need to repeat or clarify what you said, don't elevate your voice, keep it at the same level. For heaven's sake, please avoid saying things like what, huh, and a. So I'm Canadian, so a has to always go in there. But avoid saying what, huh, and a, because they're non-specific. They don't tell the other person at all what you didn't hear, what you didn't understand, what the message it didn't get through. So what you want to say to people instead is, I didn't understand the last word, can you repeat it? Or did you mean to say the dog is yellow? You can give back the information and ask for clarification, but these non-specific prompts are particularly ineffective and just lead to further conversation breakdowns. In fact, we saw that in the exchange I showed you earlier. She says, what, huh, eh? And he's not sure what she didn't understand, so he tries to repeat the whole sentence again. If she had said, I didn't understand the last part of that, he would have been able to repeat only the part she didn't understand, and the repair would have gone even more smoothly. Be persistent. Don't give up. But if necessary, walk away and come back when the time is more optimal. But whatever you do, don't abandon the conversation turn altogether. So I'm going to wrap up there just to kind of highlight some of the work that we do in our lab, and to say we're always looking for subjects. A few of the takeaways that I kind of want you to remember from today is that the conversation challenges and communication challenges that we have in Parkinson's disease are really complex. And it does take the combination of the person with PD, multiple therapies, as well as their care partner to bridge some of these challenges. No one is perfect. Mistakes are going to happen. No strategy is ever going to work all of the time. But be persistent, work together, and it will aid and support in some of the challenges that you're having. In my lab, we conduct therapies that are both interventions and training people how to do these strategies. And I know when I met with this group last time, I talked about a study we had upcoming. So it would actually train on some of these strategies using a virtual protocol. So if you're interested, reach out. But we also have several other studies that we do looking at biomarkers of cognitive impairment in Parkinson's disease and speech samples and other cognitive studies. So we're always interested in recruiting people for our work, both those who have Parkinson's disease and those who do not. And we're particularly interested in enrolling people with Parkinson's disease who have cognitive issues. And a lot of our protocols can be done virtually. I need to give a thank you to our research partners around the world, and lastly, to my incredible lab that helps to make all of this work possible. Thank you so very much for allowing me to join you today. It's been an absolute pleasure. I hope you found this information helpful, and I look forward to connecting with you throughout the day. Thank you.
Thanks, Dr. Roberts. We want to hear from you. After the summit, please take a moment and fill out a brief survey at parkinsonplace.org. Let's take a little break.
Today, we're going to think about just letting go of stuff that we really don't need to hold on to. And now pull those shoulders back and sink the chi 3 times. Inhale up. And exhale. Let everything go. Go ahead and open your mouth as you exhale. Just looking at the things, gathering up the things that were great this year, and then letting go of anything that appeared to be stressful. Again, inhale up and exhale down. Lift up one arm, inhale. Exhale, lean over to the side. Bring it around. Lift it all the way up. And exhale again. One more time. Lift up. Lean and exhale over. Switch to the other side. Lift up. Exhale, lean. Let it come around and down and lift up again. Exhale, lean over and let it come down. Once more. Exhale, lean over. Good. Turn your palms out, open wide, open your chest, and then give yourself a big hug. Open up again. Inhale. Exhale. Big hug. Bring the other arm on top. Again, lift up, open up. Exhale out. One more time. Lift up, open. Exhale. Beautiful. Bring your hands down, roll your shoulders back. Place the tongue on the roof of your mouth. Press your hips out and then come around. Notice if anything's stiff. Notice if anything needs a little bit more breath, a little bit more energy. And then when you come around to the front again, go back the other way. And again. Good. Noticing how your back, how your spine elongates. Bring yourself right to center. Bend your knees. Even if you're sitting, just lift your knees a little bit. Alternate. One more time. And then lift your arms up. Inhale up. Exhale down. Lift up. This is all about relaxing your body. So just focus internally. Recognize how your body is moving. And if there's any part of your body that needs a little bit more love, inhale, exhale. Now this time, inhale up and exhale back. Come back up, inhale, and exhale down. Again, lift up, inhale, exhale back. Come back up and exhale down. One more time, just like that. Back, inhale up and down. And relax. Let your chin go to your chest and roll your head back and forth. Use your breath. Listen for any creaks. Your own speed, just the speed of your breath. And then when you come to the center, lift your head up, lift up your chin, and then roll back and forth on the back of your body. Keep those shoulders relaxed. Don't let them inch up. Back and forth. Very nice. Bring yourself back to center. Sink the chi. And now just spend a moment breathing, paying attention internally.
Now it's time to learn about nutrition, diet, healthy eating, and food and drug interactions. Let's welcome Carley Rusch. Carley is a neurology dietitian and nutrition scientist of the Norman Fixel Institute for Neurological Diseases at UF Health.
Hello, everyone. I'm so happy to be speaking with you today here at the Parkinson Place Virtual Summit. As mentioned before, my name is Carley Rusch, and I am a neurology dietitian and a nutrition scientist. I work with Dr. Oken and Dr. Foote at the Norman Fixel Institute for Neurological Diseases here at UF Health. I'm also pursuing a PhD in nutrition at the University of Florida, where the focus of my research is on how the Mediterranean diet influences gastrointestinal health and immune function in people with Parkinson's. For today's talk, we will discuss nutrition, diet, and Parkinson's disease, and incorporate simple strategies you can implement into your daily routine. So let's get right to it. All right, so what is a registered dietitian? You might have heard of one. What's the difference between that and a nutritionist? Well, I'm here to tell you. So a registered dietitian, which is what I am, we are food and nutrition experts, and we have at least a bachelor's degree. We've completed supervised practice hours, an internship, passed an exam, and we still continue to maintain continuing education too. We practice in a variety of settings. Most of us are found in hospitals, healthcare facilities. You can even find us in sports nutrition, corporate wellness programs, private practice, food industry, universities, medical centers, as well as research. And like I mentioned before, you might be asking, what's the difference between a registered dietitian and a nutritionist? Don't they sound like the same thing? Well, nutritionists don't hold any specific degree. Anyone can call themselves a nutritionist. So all registered dietitians are nutritionists, but not all nutritionists are registered dietitians. So this is just some information to kind of give you some more explanation of who I am and what I do. And you heard me say that I'm a neurology dietitian, so you might be wondering what that is. So the definition, there's really no formal definition for a neurology dietitian. It's something that myself, Matt, who's another dietitian here, and Dr. Oken kind of came up with, and we thought it sounds great. So what my definition of that is that a neurology dietitian is a registered dietitian that works directly with individuals who are at risk or who are diagnosed with a neurological disease or condition. And this can be in a variety of settings too. And we specialize in people with neurological diseases like Parkinson's and help people who experience poor appetite, food-drug interactions, vitamin or mineral deficiencies, unintentional weight loss, diet education. We can even prescribe tube feeding management and help people with weight management and nutrition counseling too. So before diving into the details, I think it's really important to review basic concepts of nutrition and how this influences people with Parkinson's disease. So just to kind of give you a general overview of some terms that you might have heard before. So when I mentioned the term nutrition, what that means is the process of providing or obtaining food necessary for health and growth. It also refers to the branch of science, which I'm studying here at UF, how nutrients impact health and metabolism. The term diet refers to the kinds of foods that someone or even an animal or a whole community habitually eats. And then next, I want to define some key terms that you might hear in the nutrition and health space. So some of you may be familiar with these terms, others you may be new, so that's why I want to kind of go through them before we talk a little bit more about other information. So we have different nutrients and food components that can be grouped together. And the first grouping that a lot of people hear about are the macronutrients. So what the macronutrients are proteins, carbohydrates, and fats. So these provide energy for our body to function, so they fuel our metabolism. They're called a macronutrient because they provide a source of calories in our diet. So when you hear the term calorie, that's referring to a source of energy for our metabolism. Now, where you can find some of these foods. So proteins are primarily found in animal products such as meat, poultry, chicken, turkey, fish, eggs, as well as dairy too, like milk, yogurt, and cheese. And you can even find protein in plant-based sources such as nuts, legumes, and seeds. Next, the next grouping would be those micronutrients. So Micronutrients provide little to no energy, so they don't provide many calories in your diet, but they are essential building blocks for your metabolism. You couldn't function without it. So some of these micronutrients that you might hear about are different vitamins and minerals. And now when we think about vitamins and minerals, especially within this space, I think too, a lot of times we think about supplements, but vitamins and minerals are found in a lot of whole foods like animal products, as well as a variety amount in plant-based foods like your fruits, vegetables, whole grains. And then there are going to be other food components that don't exactly fit into these categories you might hear about. And these food components are considered to be beneficial to health. So one of them is going to be dietary fiber. So these are the non-digestible form of a carbohydrate that can be good for our gut health and immune function. They're found in plant foods, as well as phytonutrients as well. And we'll talk a little bit about that later. And those can also be found in plant foods too. So how does nutrition and the food we eat impact Parkinson's or someone with Parkinson's? So I like to use the expression, nutrition acts as the fuel for our body to function. So if you think about your body as a car, right? You can't start your car without gas, and sometimes you need an oil change for a little tune-up, right? So when living poor nutrition and diet can really exacerbate some of these symptoms, and some of these symptoms can even play into our food choices when we're living with Parkinson's. For example, a poor diet could lead to fatigue. And when living with Parkinson's, fatigue can play a significant role in receiving proper nutrition. You might have decreased appetite, and as well as overall decreased physical activity, and just not interested in preparing meals at home. Caregivers, this is something where you'll come into play a lot too. And when experiencing these symptoms, even for both people with Parkinson's and their caregivers, it's really easy to turn to comfort foods that are high in those calories, so remember energy, but they're low in those nutrient-dense foods like proteins, vitamins, minerals. And by not consuming enough of those nutrient-dense foods, we're depriving our body of that fuel it needs to function, which will ultimately increase our fatigue even more. So the next thing about poor nutrition is that a lot of times we think about malnutrition or weight loss. However, with someone living with Parkinson's, over the course of their life, they could actually have various changes in their weight when living with Parkinson's. Let's take a look at this image here that looks at body weight in someone with Parkinson's. I'll note that this is a generalization and it may not be applicable to every person. In the beginning, what we can see is an initial onset of non-motor symptoms that might decrease someone's food intake. And this could be slowness of movement, maybe it's GI issues like constipation or bloating, or even a decreased sense of taste or smell. Now, this is also coupled with an increase in metabolism or energy expenditure. So AKA, we're burning more calories than we're eating, which could lead to an initial slow weight loss. Now, once someone is diagnosed and they begin treatment for improved motor control, we often will see an increase in food intake and decrease in metabolism, meaning calories that we're consuming is more than calories that we're burning. And this could lead to weight gain, and in some people, maybe too much weight gain. Later on, often after someone's Parkinson's has become more advanced, we might see worsening motor control with previous therapies leading to more unintentional weight loss again and risk of developing malnutrition. And in some cases, for people who elect to receive deep brain stimulation surgery, we might see a stabilization or an improvement in their weight due to improved motor symptoms. And then going back to poor nutrition, we know that diets low in nutrient-dense foods are commonly low in dietary fiber, like I mentioned, that non-digestible carbohydrate that I mentioned earlier. And that can increase our issues with managing gut health like constipation. And I always like to say, when we think about nutrition, sometimes we only focus on foods. However, we shouldn't forget that drinking enough fluids throughout the day is just as important, as it will provide our bodies with the hydration it needs to function properly. Dehydration can further exacerbate dry mouth, poor appetite, constipation, vitamin or mineral deficiency, and increased risk for bladder infections. And I will say, this is your moment in time to grab that glass of water. Maybe it's right next to you or across the hall or the room. And cheers. Drink up. So there's also some other considerations too that you might want to consider when living with Parkinson's, like food and drug interactions. And we'll touch on this later as well. Now, I'm often asked, what is considered a healthy diet? Is there a specific diet for people with Parkinson's that they should be following? Well, the 2020 USDA Dietary Guidelines for Americans emphasizes healthy eating patterns over specific diets to help reduce risk for chronic disease. And healthy eating patterns can be adaptable as they represent the totality of all the foods and beverages you consume. Now, when developing a healthy eating pattern, when I'm working with someone, I like to use the plate method. So if you think about a plate, right? Half of the plate is going to consume of your fruits and vegetables. A quarter of the plate is going to be for those whole grains, and then the other quarter of the plate is going to be for those lean protein foods. In addition, I encourage using healthy oils like olive oil and drinking plenty of water throughout the day. Now you're like, okay, that's fine and dandy, but Carley, is there a Parkinson's diet? What should I do? Tell me something else. Well, in terms of a Parkinson's diet, the simple answer is there isn't one. Like I mentioned earlier, everyone has different needs and preferences. What works for someone might not be helpful and possibly harmful for a different person. Current research on diet and Parkinson's is either preliminary, meaning it's been cell culture studies or animal studies, or primarily observational, which could be influenced by a lot of bias in research. And I will have to say, most research look at single nutrients or those food components rather than how the entire pattern of foods that we eat influence someone's health. Much of the nutrition research in Parkinson's has been solely focused on prevention, but I think misses the mark on how we can utilize diet to improve treatment of Parkinson's symptoms. Anecdotally, some people might report that they feel better after following a specific diet. Sometimes this is because they are naturally consuming more whole foods that were missing in their diet before. Some diets have been studied in Parkinson's, including a gluten-free diet, meaning no wheat, barley, or rye, as well as ketogenic diets, which are very low carbohydrate and high fat diets. However, these diets come with increased risk of unintentional weight loss, vitamin and mineral deficiencies, which could lead to malnutrition and other side effects too. At the moment, current research doesn't support their use for treatment of Parkinson's, but we might see some new studies come out in the future. And before following a diet or wanting to take a supplement, it's really important that you discuss these risks and benefits with your doctor and or a registered dietitian before you start anything. But don't worry, I know you guys came here to talk about diet and nutrition. So there is one diet I want to talk to you more about, including its potential benefits for people with Parkinson's. And I'm sure you could probably guess since it's the focus of my research. And that diet is the Mediterranean diet. So I'm sure you've heard about the Mediterranean diet, as it's mentioned frequently over the news. It's been rated multiple years in a row by U.S. News and World Report as the #1 diet. And that's because it's been shown to be beneficial for a variety of different chronic diseases and conditions, and just for maintaining overall health. It's been shown to be beneficial for heart disease, stroke, cancer, weight management, diabetes, brain health, and even Parkinson's. So the next image I want to show you is the Mediterranean diet food pyramid, because I think this is a really great example of the components of the diet. At the bottom of the pyramid is the biggest emphasis is actually on physical activity, meaning moving. And this could range from strengthening exercises, dancing, walking, whatever movement you prefer. Maybe some of the movements discussed in the physical therapy lectures for this virtual summit. It also emphasizes a social component, and like enjoying meal with others. Now, I know the social component has been quite difficult due to the pandemic, but hopefully we're getting to a more normal pace. And that social component could even be virtual too, or at a social distance. I had one lady recently this week tell me that they have in her neighborhood a weekly dinner where everyone sits outside on their driveways and eats dinner together and chats in a socially distant manner, of course. Now, moving up in the pyramid, the biggest section is where you'll find your plant foods. That's going to be your fruits, vegetables, whole grains, olive oil, beans, nuts, legumes, and seeds, as well as herbs and spices. As we move up, you'll find more protein sources from the diet. So that's going to be highly emphasizing fish, seafood, with moderate amounts of poultry, eggs, cheese, and yogurt. And then at the tippy top of the pyramid, that's where you're going to find the foods that we should eat less of. And those are going to be your red meats and sweets too. And it's important that this diet highlights the emphasis on staying well hydrated with water. And if you do drink alcohol, moderate consumption of red wine. If you don't drink alcohol, I always say we don't suggest you start. Studies have shown the health benefits of the Mediterranean diet can aid in lowering the bad cholesterol like LDL and elevating good cholesterol like HDL. It's also been shown to lower blood pressure, prevent heart disease, stroke, possibly reduce symptoms of depression, and may even delay or prevent age-related cognitive decline or memory function. And I often like to emphasize that the Mediterranean diet is not a one-size-fits-all approach. Often when we hear the Mediterranean diet, I'll have people ask me, well, Carly, does that mean I have to eat like the people from Italy and Greece? What if I don't like those types of cuisines or foods? Well, good news for you, you don't have to eat those types of cuisines, right? It's a very adaptable diet. It's just representing the totality of foods. So for example, maybe you enjoy a piece of chicken, potatoes, those can be incorporated. Or if you like curry type dishes with lentils and fish and vegetables, you can incorporate that as well. So you don't have to eat like the people from the Mediterranean Sea to incorporate a Mediterranean diet in your lifestyle. And some studies have shown that eating a Mediterranean diet pattern might aid in reducing your risk of developing Parkinson's and possibly even delaying the age of onset of Parkinson's symptoms too. But that's kind of it. That's all we really know. And more research is actually being conducted in Parkinson's, actually here at UF. And that's because very few studies have actually implemented a diet intervention to improve motor or non-motor symptoms in people with Parkinson's. So at UF Health, we plan to track how Mediterranean diet adherence correlates with outcomes in Parkinson's disease. And if this sounds great to you, Then on this next image, I'm going to show you that we're actually recruiting people for our Mediterranean diet and Parkinson's study. So what we're looking for are people with Parkinson's who experience at least slight constipation symptoms. And to qualify for if you're interested in this study, I'll just tell you a little bit more information about it. So I know the focus of this group is based in Florida. So if anyone is willing to, but I know there's some other people around this country as well that might be joining in. And if there's anyone willing to travel to Gainesville, we will be holding 3 in-person study visits for the study over the course of 10 weeks. We'll conduct other study procedures virtually over Zoom or by phone. And what this study is a 10-week study, and we're looking to determine if a Mediterranean diet can impact GI function in people diagnosed with Parkinson's disease who experience at least slight constipation symptoms. And because it's a diet intervention, people will be put into one of 2 groups. So the first group is going to be that control group, right? So we're controlling for any potential bias in research. And that's what makes the quality of this research really strong. So the control group will receive standard of care for constipation. So that is simply a handout. It's something that if you were to go to your neurologist and you said, hey, I'm having constipation, what should I do? It is a simple handout that you could receive. Now, if you're randomized to the intervention group, you'll also receive that standard of care, so that handout, but you'll be provided the Mediterranean diet education too by a dietitian like myself. So we're looking for people between the ages of 40 to 85 years old who've been diagnosed with Parkinson's. You must have at least slight constipation symptoms over the course of a week. And you must not be considered underweight, have no history of deep brain stimulation surgery, and there might be some additional criteria that will apply. We will provide compensation throughout the study, as well as light breakfast at study visits, diet education by myself with weekly phone calls to help improve your adherence, and we'll also be measuring body composition during these visits as well. So if this is something that interests you and you're willing to make the trip to Gainesville, I highly encourage you to check out more information, and you can do this one of 2 ways. You can go to our link, which is the tinyurl.com/M as in Mediterranean, P as in Parkinson's, D as diet, study, or you can call 352-340-7321, and we'd be happy to give you more details and information about the study and see if you qualify. So now if you can't participate in this study, but you would love to incorporate these principles at home, I encourage you to audit your current diet and eating habits. Think about what foods could you include more of? Are there foods you should eat less of? And then from there, you can slowly start making changes to be more adherent to a Mediterranean diet. And there are a number of books and recipes you can find online to really help guide you through that too. Now, shifting gears, I mentioned food and drug interactions earlier. So let's discuss more on this topic and strategies for managing. So when I talk about food and drug interactions, I'm mostly going to talk about that carbidopa and levodopa medication, or Sinemet. And that's a medication used to treat Parkinson's. And why we use this medication is Parkinson's is the loss of dopamine neurons in your brain. Levodopa, part of that carbidopa levodopa, helps make more dopamine. But our body can't take levodopa by itself, so we need that carbidopa to help improve the absorption of levodopa. Now, think about whenever you're taking a medication, right? You have to put it in your mouth, swallow it, it goes down into our stomach, and then into our digestive system to be absorbed. Now, when it's being absorbed, there are different transporters along our GI tract that levodopa will absorb through. And dietary proteins may also share those transporters, aka may cause an interaction with absorption of levodopa. And it's not just in our gut that protein could potentially interact, but it also can occur in our brain. And this might lead to delayed on time and early wearing off. But I don't want you to be scared of protein based off me saying this, because most studies that have investigated this interaction, and just with working with hundreds of people in practice, we primarily see this occur in more advanced stages of Parkinson's, particularly in people who've been living with Parkinson's for over 10 years. So same thing, just because it affects one person, it might not affect another person. And I want to give you some examples of how that might be. So in practice, some of the protein cinnamon interactions will really vary greatly on a spectrum. So let's take our person 1, for example. They were recently diagnosed with Parkinson's, prescribed cinnamon, and they take it with meals 3 times a day. They get good on time 30 minutes after taking it. No interaction, no issue that they're aware of. Now, we have the next person who might be living with Parkinson's for maybe it's something like 6 years, right? And they take their cinnamon 30 minutes before meals 4 times a day. They get on time 20 to 30 minutes after, no interaction there, but they need to make sure that they time it with meals appropriately. Now, I have our next person. Maybe they've been living with Parkinson's for 15 years, and they try to take that cinnamon 30 minutes before meals 5 times a day, but their on time is kind of variable. It might be 30 to 60 minutes after, just really depending on the food they eat at their meal. So a lot of variation. So just because foods and proteins might interfere with someone, it might not always be the case for a different person. And when managing these food and drug interactions with Cinemet, often we just focus on the protein. However, sometimes we need to focus on the volume of foods that we're eating too. And that's because someone with Parkinson's could experience delayed stomach emptying, aka if your stomach empties slower, then we're getting delayed absorption of that medication too. Now, there are foods that can delay that stomach emptying too. So foods that can delay stomach emptying are proteins, of course, but also fats and some dietary fibers. Now, this might explain if you've ever experienced decreased effectiveness in your medication after eating out at a restaurant or maybe having a big meal at a friend's house. So I gave a talk a few years ago. Someone raised their hand to ask me a question. They said, why is it when I go to the Olive Garden that my medication doesn't work as effectively? They're like, I take it 30 minutes before and I just don't feel like I get as good of benefit after I go to the Olive Garden. So I asked him, well, what do you eat at the Olive Garden? Do you get a salad? Do you get some breadsticks? Do you get pasta, right? Those are all really big, heavy foods in combination with each other. And so that's really going to delay that stomach emptying or delay that medication absorption. So sometimes it's not just the protein that we need to think about. It's the size of our meal and maybe the fat content too. So some general recommendations that I provide people when taking Cinemet, especially if you're unsure if you're having an interaction, is to take it on an empty stomach 30 minutes before meals or 1 to 2 hours after a meal. Now, you might need to adjust this timing as needed depending on the effectiveness and your preferred schedule. Some people can tolerate with food, and others may need a little bit more time fasted. Remember, everyone is different, but I often find that trying to time it after a meal definitely doesn't work for most people. I always say try to really time it before that meal. Now, some of you might be thinking, ugh, Carly, I was told to do it on an empty stomach. I did. I got so nauseous, I could not tolerate that medication at all without food. And if you've experienced that, you are not alone. So I do have a handful of people that are more sensitive to meal timing with Sinemet. And one of the main recommendations that I give someone, especially if they have nausea when they're taking their medication on an empty stomach, is I take in those principles of how our stomach empties, right? So I tell someone to pair that medication with a simple carbohydrate. So what I mean by a simple carbohydrate is maybe it's a simple sugar or food. And that's because it doesn't have to be a lot, just a little bit to help coat the stomach. And that's because it's quickly digested. It's not going to affect your stomach emptying. It's not going to sit around in your stomach where it would compete with levodopa. So some examples of a simple carb would be maybe half a cup of juice, or a tiny amount of soda, ginger ale, maybe a piece of white bread, crackers, etc. I had one lady who definitely had pretty severe nausea with Sinemet on an empty stomach, and her simple carb trick was 1 Eggo waffle in the morning with a little sliver of jelly on top, and that's how she took her Sinemet every day. Now, in more complicated cases, sometime a protein redistribution diet might be appropriate. And what this means is the greatest amount of protein is shifted to the time of day when the interaction is the lowest. So that's typically in the evenings. And before incorporating any diet strategies, I highly encourage you to talk to your doctor or a registered dietitian to discuss more tailored approaches for managing this food and drug interaction. And that's because if you are scared of protein, avoiding protein in your diet and just meals in general, skipping meals, can really increase your risk of developing malnutrition because of that low protein and calorie amount from the diet. And there are other medications that someone with Parkinson's might be taking. So that could be Mirapex, Nupro, and Requip. Now, if you're taking any of these medications alone, they don't actually interact with dietary protein, so you don't need to worry about this interaction. However, you want to keep in mind that some of the side effects might impact if you take it with or without foods, or it might impact your food choices too. So that's something to pay attention to. There are another class of drugs called MAOB inhibitors. So this is Azilect, and these do not interact with most dietary proteins. However, they could increase your level of the dietary compound called tyramine, which could influence your blood pressure if consumed in large amounts. So high tyramine foods are found in alcohol, aged cheeses, cured or fermented foods, soybean products like soy sauce, tofu, or miso. If you are on one of these MAOB inhibitors, that's okay. You do not need to avoid these foods. It's just mentioning that you might want to consider the amount of those foods that you're consuming and avoid consuming too much in one sitting. So now that we've talked about nutrition, diet, and food-drug interactions in Parkinson's, I would love to share my 5 strategies to improve your nutrition game plan. So the first strategy is going to be pick one day of the week to create your game plan. So this is probably a tip for a lot of the caregivers in the room too, who might be doing a lot of the meal planning and grocery shopping. So I want you to think about your week ahead. Do you have events with family? What does work look like? Are you traveling? What days of the week are easier to shop and prepare meals at home? Now, it doesn't have to be one day of the week. It actually could be broken into 2 days of the week if needed. And then next, I want you to think about what types of foods or recipes do you enjoy? And when it comes to this, I always tell people, especially if they feel like they are getting bored with their choices of meals throughout the week, I recommend that anytime you're trying something new, maybe it's a new recipe or something that you made at home, write it down on a list of favorite foods. So that way when you feel a little stuck, maybe fatigued, you can have that list of favorite foods and snacks to refer to. Make it a little bit easier to plan. And then another tip for planning is to plan meals around weekly sales for savings. I always love the Publix weekly ad. That's what I always use. Now, once you've made this plan, I want you to make a grocery list and then stick to it when you go to the grocery store. You can look up new recipes online or in cookbooks. Keep a list of favorite foods that you can refer to when feeling stuck or in the kitchen. Double check the items you need with the items you already have. Keep basic food staples in your pantry. This would be whole grains, nuts, olive oil, herbs and spices, and then buy in bulk if possible. My third tip for improving your nutrition game plan is to double or even triple your recipes that you can eat throughout the week or you can freeze for later. I really love to use those meal prep containers to portion out foods for the week and then reheat to decrease time in the kitchen. And you can find these containers in most retailers like Amazon, Walmart, even Publix. And what I like to do is when I'm preparing a meal at home, I will bring out those containers and then portion out each of the individual servings on my plate and then into the individual containers too. That way, when it's time to eat, all I have to do is pull it out of the fridge, heat it up in the microwave, and eat it. You can also freeze foods like chilies, soups, fresh fruit, vegetables to decrease time in different weeks. My fourth strategy is to power up your plate with more fiber. You can tell there's a theme here. This will help promote bowel regularity, like constipation, and certain fibers can even promote satiety and regulate cholesterol and blood sugar levels, and that's something like oats. Eating a variety of fiber-rich foods like fruits, vegetables, legumes, peas, whole grains, nuts, and seeds can be really important. And you utilize fiber supplements when needed. And I always recommend working with your doctor or a dietitian to find the right fiber supplement for you too, because there's lots of different types that might be beneficial. And then my fifth and last strategy for improving your game plan is going to be to look up healthy options at your favorite fast food or restaurant. Think about, are there grilled options available or baked options? Can you choose a side of fruit or garden salad over fries? Take into account that plate method. So fill half your plate with those vegetables or fruit. And then for larger portions, split half of the entree with someone or take the other half home for later. So I like to use the example that Chick-fil-A is one of my favorite fast food places to eat healthy. Now you're like, Carly, how can you eat healthy at a fast food restaurant? Well, Chick-fil-A has plenty of grilled chicken nugget options as well as salad options or even a really nice fruit cup too. So depending on the day and depending on what my diet has looked like for the week, if I'm in the mood for fast food, whether it's from a craving or if maybe I'm a little bit too busy to prepare something myself, what I will do is decide, okay, where am I going to choose a healthy option and maybe where am I going to give into that craving, right? So maybe some of the days it's choosing the grilled nuggets with a side salad, right? But, it doesn't always have to be that clean, right? Sometimes the healthy choice for you is maybe you just really want to have fries that day, and that's okay. It's one day to have fries. But you care less if you have the fried nuggets over the grilled nuggets. So maybe this next day, the next healthy choice that you make is instead of fried nuggets, I'll have the grilled nuggets with fries. You see where I'm going? It's not a one-size-fits-all scenario. you can adapt these food choices based on your needs and just how you're feeling that day. But you don't always have to stick with the fried food options every single day. And to make healthy eating choices easier at home, I want to show you 2 recipes for living and eating well. And that first recipe is going to be a mixed green salad with chicken and pistachios. I love this recipe because it's a Mediterranean style recipe that's high in antioxidants, healthy fats, and if you think salads are boring, this salad might change your mind. So for this salad, it serves 2. The ingredients are going to be 3 cups of raw kale with the center ribs removed and coarsely chopped, 4 tablespoons of olive oil, 2 tablespoons of lemon juice, and that comes from about 1 small lemon, half a teaspoon of black pepper, 2 cups of arugula, a 1/4 cup of shelled pistachios, 3 tablespoons of grated Parmesan cheese, and 6 ounces of grilled or baked chicken cut into strips. Now, if you're looking for a convenient option, choose pre-made grilled chicken at your local grocery store if it's available. And if you're a vegan or a vegetarian, you can add sauteed tofu or tempeh in place of chicken here and leave out the Parmesan. So now let's take a look at how to prepare this recipe. So in a large salad bowl, I want you to combine the kale, oil, lemon juice, and black pepper. With your hands, gently massage the leaves for about 15 seconds until all leaves are thoroughly coated. You'll set this aside for 10 minutes. When ready to serve, mix in the arugula, pistachios, and Parmesan cheese. And again, if you are a vegan or a vegetarian that doesn't eat cheese, you can leave this out. And then divide the salad and chicken strips among 2 serving bowls and serve. And enjoy. I promise you'll love it. Now, let's go ahead and take a look at the second recipe I want to share with you. So that's going to be a neuro smoothie. And this was developed by one of our other dietitians here at the Fixel Institute, and his name is Matt Beck. What I love about this smoothie is that it's high in calories, high in protein, and it's great for anyone looking for a meal replacement that's healthy. It's also good for anyone who has difficulty chewing or swallowing. And I always like to say in clinic, you want the best bang for your bite because you don't know how many bites you're going to get, right? So if you struggle to maintain your weight, smoothies are great options to pack in more nutrition and less volume. So this smoothie serves 1 person. Now we're going to take a look at the ingredients. And it's going to have 1 cup of a frozen berry mix, and you can mix this up too between blueberries, blackberries, raspberries, 1 cup of strawberries, a couple handfuls of spinach, an 1/8 cup of walnuts, an 1/8 of a cup of vanilla yogurt, and 8 ounces or 1 cup of a soy milk, almond milk, or 2% milk, whichever you prefer. And then for protein, you're going to add about 1/2 of a scoop of a chocolate protein powder in there. Using a blender, first combine the frozen berries, strawberries, spinach, walnuts, yogurt, and milk, and you are going to blend this until smooth and the ingredients are incorporated. Once incorporated, add 1/2 a scoop of the chocolate protein powder and mix until combined. And I want to note that by adding the protein powder last, you prevent the protein powder from expanding, which can change the taste and increase the volume when it's overmixed. After you're done, pour into a glass and enjoy. So, to conclude, nutrition and diet is incredibly important when living with Parkinson's disease. Nutrition acts as that fuel for our body to function, and while there's limited diet research in Parkinson's, the Mediterranean diet is promising and may promote other health benefits. For specific recommendations based on your goals and needs, I highly recommend reaching out to your doctor and or working with a registered dietitian to come up with an individualized meal plan. Right now, I'm only able to work with people who are seen by providers here at the Fixel Institute, but if you don't see anyone here at the Fixel Institute, I'm absolutely happy to answer any general questions you might have and or direct you to any resources that are available. If you'd like my email, it's going to be crusch, so CRUSCH 792@ufl.edu. Thank you to the Parkinson's Place and everyone for allowing me into your homes to talk today. Have a great day, everyone.
And now, speaking of nutrition, let's take a quick lunch break. We're going to watch the short documentary Parkinson's Third Wind, directed by Peter Barton and produced by Groundswell Media. The summit continues in 15 minutes.
Daddy.
John!
I found out that I had Parkinson's when I was 59 years old.
I was diagnosed March 31st of 2009.
In one of the support groups, there was a woman who said she gives herself 5 minutes to cry every day, and then she has to be done.
And I remember thinking and saying that this is going to have an impact on my riding my motorcycle into old age. I know the message can be incredibly difficult to hear, but it's not the end of life. Ideally, that does not define who you are.
The first things that concerned me when I learned I had Parkinson's was, how will you know if I smile? Because, the face becomes masked.
I'm living life while I can, to the best of my ability. Is it a second wind? Maybe. But it's our third and fourth and fifth wind.
Thrown to you, but it's how you react to it.
Peace, salam, shalom. Peace, salam, shalom.
No one wants to have PD. I have PD, but it doesn't define who I am, and it shouldn't define who you are.
You move on.
It's been just a great joy to meet other people, those that have PD and those that are partners, caregivers, care partners with people.
If you had told me I was going to join the choir, I would have laughed my head off. And yet I love it, and I think it really helps me with my vocal intensity. I can't imagine my life without Parkinson's. I can't imagine not having the people in my life that I wouldn't have met had I not had Parkinson's.
So it's a blessing of sorts.
I could do without the symptoms.
Yeah.
Wednesday, I do boxing.
Go big, go strong, fight this beanie all day long.
When I was on the train once, and I was with somebody else who was a boxer, a lot of people could overhear our conversation, and she was talking about how we do boxing, and heads turned, you do boxing?
One more? You got it. Good, good, good.
Yeah, I'm tougher than I look.
Well, the benefit of boxing for me has been the fact that I'm able to get some of my frustrations out. And there are times when having PD, as you feel the frustration so much, you want to shout and scream. But the boxing helps me to release it.
I find that the exercise really makes such a huge difference. When we do the cardio at boxing, before we do the actual boxing, sometimes we'll march. And the higher I lift my legs up, the easier it is for me to get on the train.
When I say just let it rip, this is what I see. Legs lock out.
Yeah.
What I don't see is the whole body. One, rear, hook, gut, blow. One, jab, cross, hook. Right, left, right. Very, very good.
It's a way of fighting back.
Good. Last two. And one from the top.
It's much more exhilarating than I ever imagined. It's more exhausting than I could have ever thought about. I'm feeling different energy.
Up, shift back. Left, right, good. 2, 3, 4. Up.
You can do it. We can all do it. We can do it to the best of our ability.
I scream, you scream, we all scream for dopamine!
When I first had read articles about how people with Parkinson's, their creativity became enhanced, I was really disappointed because I wanted it to be me. But it is me. You know, Parkinson's is there and is a part of me. So I might as well reap some benefits here. And I'm reaping the benefits. I didn't see myself as an artist before. I didn't have to draw. Now I have to draw. I mean, how can you not do it if it makes you feel so good? You know? I mean, I don't drink, I draw. It brings me a lot of pleasure. It brings me a lot of peace. It does remind me of meditating because it's almost like your whole body is slowing down. I'm functioning on a different plane.
And for me, it's that door where one door closes and another opens. It's enabled me to think about now. My creativity has just blossomed. I couldn't paint at all before, at least I thought I could. And so I discovered that I can paint. And that's just been such a joy. My wife would say that she believes that my creativity was there before. In other areas, for example, photography is a hobby of mine, has been for probably 30 years. And she would say I had creativity there as a basis, but this incredible drawing, painting has emerged that has enabled me to look at art differently. This is my mom's restaurant, a diner, when I was a kid. Ordinarily, there are times when my hands are in motion, and it's the tremors. And when I'm painting, there's a liberation of the freedom. For me, it's worked very well when I'm able to do these things. And so at times it just surprises me that my hand's not moving all over. I have not had an education in painting as such. And sometimes I've painted something, I thought, oops, what a mistake. And then I realized that I could paint that into whatever I was working with. And again, this is evolving literally as I speak. I'm not sure exactly what I'm doing. I'm having fun though. Whatever time I have, I want to create whatever I can while I can. And there are times I just don't want to stop. There are times I'm here at 2 o'clock in the morning. I lose track of time. I feel free of PD. In addition to painting, I discovered that I love to write and express my emotions, my feelings. I think of it as reflections. This is called One-It Man. This is among my first that I really reflected on having Parkinson's disease. Unexpectedly, I caught a glimpse of you today while I skipped a beat walking down the street. I struggled with... One-It Man was an expression to be able to say, here's what I'm feeling, the sentiments of having PD. That people could visually see that I have PD. And I didn't want them to see it, but I couldn't get rid of it. It's still there, and it was obvious. I thought of you today, not because I wanted to. I thought of you today, like a one-it man. I write profusely. I'm writing amazingly every day in some fashion. Here, for example, is something called Speak to the Child Within. I sit here now with a smile on my face, remembering when I was once young and innocent. Not that I wish I could go back in time, but it warms my heart simply to recall the very first time I played and even danced in the rain. For a brief moment, I forgot. It's been a blessing to discover that I have this voice. I do feel at times, when I'm writing, for example, at 2 o'clock in the morning, and I have something I've called the phantom writer. I just wonder where it comes from, the words. Where do I get some of these images that I paint? I don't know. I just feel that there's something there that's deeper than me.
I'm so excited about this. Art is something that just lives, and it will live beyond me. It should. So it makes me feel good if I think about, leaving artwork, but I'd rather think about seeing the artwork in someone's home now. I'd rather live in the moment, live in the day.
I think Betty's art is tremendous. It's phenomenal.
I think it's amazing.
The way that she expresses her feelings using the art, it's incredible. So for me, watching the joy that she has and the fact that it helps in recovery is critical, and it's a blessing.
And it captures her spirit. She's just the most tranquil, peaceful person coming to grips with an illness and integrating it into her life and not letting her stop her.
I have many people who say that I motivate them and that I'm inspirational. They see me as a person who has Parkinson's, but just as a person, I'm not defeated by that. I'm actually inspired by that. I've got all this creativity that is expanded from what it was before, and I've just got so many projects going.
It's been a journey of love. Probably 150 reflections, as well as my artwork, photographs. Perhaps I can help someone else. Perhaps I can even inspire someone else. There's still vibrancy in me, because I'm here, I'm now. I'm in the present moment. I'm alive. 50 to 60,000 people a year in the United States will be diagnosed with Parkinson's disease. I'm ready for a cure. I am so ready because I'm concerned about my grandchildren. Yes, I have Parkinson's disease, but that's not me. I'm more than PD.
And you said you would know. Mm-hmm. And I do believe you would know. You would look me in the eye and just know, kind of like how we know what each other is thinking. You would know that I'm thinking a smile is there.
Gotta put one foot in front of the other and lead with love. One foot in front of the other and lead with love. Lift up your eyes. Don't you listen. Look up ahead. Look and listen. You gotta put one foot in front of the other. Swing it. Lead with love. One foot in front of the other and lead with love. You gotta put one foot in front of the other and lead with love. One foot in front of the other and lead with love.
We're back. If you would like to see Parkinson's Third Wind again after the summit, go to parkinsonplace.org. Just click on the link. Now, let's take a moment to thank our sponsors who helped make this summit possible. Our gold sponsor is Accorda.
Hi, I'm Ron Cohen. I'm founder, president, and CEO of Accorda Therapeutics. I'm very happy to be here today to talk with you about Imbresia. So first, the goal of Parkinson's therapy is to maintain control of symptoms as best as possible. People with Parkinson's experience fluctuations in their symptom control, and as the disease progresses over time, those fluctuations can become more frequent and or more severe. And that's despite taking your regularly scheduled Parkinson's medications exactly as they're prescribed. Off periods are when Parkinson's symptoms return. You can think of it as turning off or your drugs turning off and not working as expected. So when they are working as expected, you're in the green zone. Your symptoms are controlled. As the drugs no longer are controlling it, you enter into a yellow zone, or sometimes you can suddenly go into a red zone. It's variable depending on the individual. But this means that symptoms are returning before your next dose of medication is scheduled. Now, what does that look like or feel like for someone who has Parkinson's? Well, it varies tremendously by the individual. It depends on your particular individual symptoms, your particular individual Parkinson's disease. And it may be easy or difficult to recognize when your symptoms may be returning, how severe they're going to be, how long that situation is going to last. So it can be quite frustrating precisely because it is so variable and can be so unpredictable. And here you see a list of what many people with Parkinson's experience when they have off periods, and you might have one or more of these, you might have most of these. Again, it depends on you, the individual. This slide helps illustrate why people with Parkinson's can get return of symptoms, even though they're taking their regularly scheduled medications as prescribed. And you see here, oral carbidopa-levodopa enters the mouth, the esophagus, the stomach, then into the intestines, where it's absorbed, ideally, into the bloodstream and then goes into the brain. However, in Parkinson's disease, the disease itself can slow down the gut. And this can prevent or slow down absorption of your medications so that you're not getting them as prescribed, even though you're taking them as prescribed. There are other variables such as what you eat. So meals, for example, that have high levels of protein can also slow absorption. And for all these reasons, people with Parkinson's find that they can get return of symptoms even though they're actually taking their regularly scheduled medications. So Inbrija was developed specifically to address these issues. It is the only inhalable form of levodopa. It is used when needed for off episodes, and it's in people with Parkinson's who are taking a regular regimen of carbidopa-levodopa. Inbrija was also designed to be lightweight and portable, so you can take it with you anywhere, outside the house. You can use it inside the house, in the car. You can put it in your pocket. It's very easy to carry around. I have one in my pocket to illustrate this for you. Here it is. It looks like what you see on the screen. So this slide illustrates what we've been talking about, how Inbrija works. And you can see you inhale it, it goes into the lungs, and then up into the bloodstream and into the brain. It does not depend on your digestive tract or gut to be absorbed. And so the Parkinson's effect on your gut does not come into play here. So Inbrija is intended for when you realize your symptoms are returning. And ideally, you should take it when your symptoms are starting to return. If you remember that earlier slide with the thermometer with red, yellow, green, when you're moving from green to yellow and you realize that your drugs are just not controlling your symptoms, that's the time to reach for Inbrija. You can reach for it if you've gotten all the way to red, you can still use it. It's just that you have your best chance to get the best results the sooner you take it when symptoms start. In a large clinical study, Inbrija started to work as early as 10 minutes, and 10 minutes was the earliest that we looked at that. By 30 minutes, there was significant relief of motor symptoms, and that relief lasted up to 60 minutes, which is the latest that we looked at it in the study. The effect on non-motor symptoms was not looked at, so the effect on those is unknown. I should mention that the most common side effects of Inbrija were cough, upper respiratory infection, nausea, and also a change in the color of saliva or spit. And that's because levodopa can turn brownish or blackish when it's exposed to air. So that's simply dealt with by rinsing your mouth and it goes away. So where can you go to get additional information to consider getting Inbrija? First, we have a website, www.inbrija.com. You can find all kinds of resources there. There's a helpful hints guide. There's a guide to talking with your healthcare provider about Inbrija. There's a demonstration video, and you can also sign up there to receive additional information. We have educational programs on video at www.learninbrija.com. These are led by experts in Parkinson's disease, as well as people with Parkinson's who have been taking Inbrija and are talking about their personal experiences. Now, if you're taking Inbrija, you should tell your healthcare provider if you experience any of the symptoms that you see here on this slide. Most of these are common to any drug that contains levodopa, and if you're taking Inbrija, by definition, you're also taking another form of levodopa. So hopefully these will be familiar to you. The one I do want to point out as specific to Inbrija is bronchospasm, because it is an inhaled form of levodopa, and people with asthma, COPD, or other lung diseases may experience wheezing or difficulty breathing if they inhale Inbrija. And if so, you should stop taking Inbrija and seek medical attention. If you're discussing with your healthcare provider potentially using Inbrija, you should make sure that they know about any existing medical conditions. And again, if you've taken a levodopa preparation, most of these will be familiar to you because they are common to any levodopa type drug. The one that, again, would be specific to Inbrija is the first one, asthma, COPD, or any other chronic lung disease. It's also important that you use Inbrija as directed by your healthcare provider. You should take Inbrija, again, as soon as you feel that your symptoms are returning in order to get the most out of it. One dose is equal to 2 capsules, and you shouldn't take more than 1 dose for any given off period. However, you can take a dose for up to 5 periods, up to 5 off periods a day, and you shouldn't take more than 5 doses a day. The capsules are meant only to be inhaled. You shouldn't swallow them. You should not open them. And very important, Inbrija does not replace your regular carbidopa-levodopa regimen. However you are taking that, it is meant as an adjunct to that so that you can get better control over your return of symptoms or off periods. A few additional points. As with any levodopa-containing drug, you should tell your healthcare provider if you take any of the other drugs that you see listed here on the screen. And as with any levodopa preparation, if you're starting Inbrija, you shouldn't drive, operate machinery, or do other activities until you know how it affects you. Sleepiness and falling asleep can happen as late as a year after treatment is started. Thank you for spending this time with me to talk about Inbrija. As I mentioned, from the first time I saw it, I was excited about it. As a physician, I always believe that the best advocate for the patient is the patient. And the best person to take control over their condition is the patient. And as a physician, I try to help that as much as possible and empower the patient as much as possible. And that is what I see is the role for Inbrija. So I hope you'll take advantage of the resources we just talked about, and thank you again for the opportunity.
Silver sponsors are Amneal, Suncoast Blood Centers, Care Patrol, and Medtronic. Bronze sponsors include Sunway Senior Living Concierge, Seniors Blue Book, Kizik Hands-Free Shoes, The Starling Group, Doctors Hospital of Sarasota, Our Y, CND Life Sciences, and Achieving Wellness Group. Also, James Ferrara, lymphedema therapist, provider of LSVT Big and Sarasota Contemporary Dance. Rebecca Henson is a physical therapist of Doctors Hospital of Sarasota. She has a master's degree in physical therapy and nutrition and is a registered dietitian. Rebecca is sharing tips on falls prevention, posture, and balance.
Hi, I'm Rebecca Henson, and I am a physical therapist here at Doctors Hospital. We are here on the 3rd floor in one of the beautiful patient rooms, and we wanted to talk to you today about Parkinson's disease and fall prevention. Fall prevention is such an important topic for everyone, but especially for those of you with Parkinson's disease. I wanted to cover a bunch of important topics for you today about how to prevent falls and home safety for people with Parkinson's disease. First thing is vision. Vision changes happen as we get older. It happens to the best of us, but especially for people with Parkinson's disease, one thing that you can do is make sure that you wear your corrective lenses when you're up and about so that you can see appropriately when you're moving. And the other thing about vision changes that's important for fall prevention and safety is to make sure that there's adequate lighting. Even if you're getting up at night to go to the bathroom, that's a frequent fall time. Either having night lights set up or actually turning on the lights for full lights so that you can have a great visual for safety when you're going to the bathroom. So here we have our amazing patient care technician, Renee, from the 3rd floor, helping us demonstrate a safe get up and go. She's going to preserve energy. What we do is called log rolling out of bed. And this technique prevents any damage to your back, and it's a little bit easier so you don't expend as much energy trying to get up. So what she's going to do is bend her knees, roll onto her side. She's going to now lower her feet towards the ground and use that momentum to push up onto her elbow and up into the seated position. And now Renee, because she's so smart, she's going to sit for a while before she pops up to make sure that she's not dizzy. She's going to put on her glasses so that she can see and not fall over. And she's going to make sure her shoes are on or whatever non-slip footwear so that she's not going to slip. The light's already on, otherwise she would turn on the light. And she's going to grab her walker, which is right next to the bed, so she doesn't have to get up without it. And then once she's sure she's not dizzy, she's going to stand up, one hand on the bed. And then she's going to make sure she's not dizzy. If she gets dizzy, she can sit right back down. And once she knows she's not dizzy, off she goes, picking up her feet, making sure she clears. Big steps. Another thing that's really important when it comes to safety, fall safety and home safety and fall prevention for people with Parkinson's disease and everyone is strength. So a lot of times as the disease progresses, you might notice that you have some weakness in your legs or weakness in your core. It may be hard to sit up in bed. It may be hard to stand up from a chair. So it's extra important for you to do some strengthening exercises. And if you don't know what to do, to work with a physical therapist. We have great outpatient physical therapy here at Doctors Hospital, and there's other great outpatient physical therapy departments around town. And a trained physical therapist is the one who can help you with tricks and tips to get strong in your core and legs so that you can transfer and walk easily and without danger or risk of falls. Now I'm going to show you my two favorite exercises to improve your balance and safety at home. I'd like you to do this at the sink. This could be the kitchen sink, or my favorite is the bathroom sink, because I'd like you to do this twice a day, in the morning and the evening, every time you go to brush your teeth. You're going to use the edge of the sink to hold so that you don't fall. And the first thing you're going to do is actually balance on one leg. So I want you to practice, and this might be hard at first. And once it gets easier, I'd like you to try to lighten up your grip. So leave your hands nearby in case you fall and you have to grab, but I want your hands there to lighten up so that you can really practice balancing and see how long you can balance on one foot. If you get really good, you can actually start to try to brush your teeth on one leg with your hand here to make sure you don't tip over. And that's the challenge, is to be able to brush your teeth on one leg. And here's why this is so important. Because when you're walking, it's a series of being on one leg, and then the other leg, and then the other leg. So if you can't balance on one leg, that's why you might start to shuffle or be insecure taking big steps, and then that shuffling leads to a fall. So practicing and being able to balance on one leg is super important, and it will get easier very quickly. If you've never done these exercises before, you'll be astounded that within a week or two of doing this twice a day for a minute, you'll be so much better balanced. My other favorite exercise right here for Parkinson's patients is to hang on and do big knee ups, big marches. So you want to see your knee get all the way up to your hand, almost all the way up to the top of the counter if you can. And that will help you assess how big your step is. And that helps strengthen the muscles that make you capable of picking up your feet when you're walking, again, so that you won't shuffle and fall. So those are my two favorite exercises: balance on one leg, try to get where you don't need your hands as much, and then hold on and do a high march. Maybe start with 10 on each side and see how many you can work your way up to. Another thing that's really important with Parkinson's disease that some of you may have experienced, or you may know someone that has experienced, is freezing. When you come up to a threshold or something that catches your eye that causes your body to freeze. And that, combined with another safety issue that's common in Parkinson's disease, is loss of center of gravity. So center of gravity when you're standing should look like this, but sometimes with Parkinson's you may notice that when you look in the mirror or you catch a picture of yourself that you're leaning forward. And so that is a risk, because this is your best balance point. So when you're doing this, it puts you at risk to fall forward. And then if you are walking and your momentum is forward and you freeze, it can cause a forward fall. So what do you do about those things? If your forward center of gravity is getting to be an issue and you notice that you're at risk for falling forward, that's when it's probably appropriate to start using a walker. So using appropriate safety devices, and the walker is helpful because you can lean into it forward and it will prevent that forward fall because your arms can help in that scenario. You could imagine that if you freeze, combined with your loss of center of gravity forward, the walker could help. And then how do you get going again? What if you start freezing up a lot? There are some tips and tricks I can tell you today. And then if it's happening even more, again, going to a trained physical therapist to work with you specifically to see your best tips for unfreezing is a great idea. So some simple tips for if you freeze up are just to count. 1, 2, 3, go. Sometimes just your brain is perseverating or stuck thinking about that next step. If you can switch your brain to think about counting, 1, 2, 3, go, you'll go. Another thing to trick your brain into unfreezing is to just do something else real quickly, not quickly, but to do another activity, like take your hand and touch your forehead and put it back on the walker and then go. It just gets your brain unstuck from thinking too much about that next step. Another thing that I'm sure you know happens to people when Parkinson's disease progresses is what we call shuffling gait. And that's when you're not picking up your feet and you're not making big movements, so it becomes a tiny step and you don't actually pick your feet up off the floor. So what do we do about that? And why is that risky? That's risky because anytime you have a transition in the floor surface, like hardwood to carpet, if your foot is dragging on the floor, it could catch that carpet and then you tumble forward. Also, this is the reason why we don't want any throw rugs, anything laying on the ground that you could trip over, like a book or clothes laying on the floor or towels laying on the floor. Be very careful, and that's another place that a physical therapist could be helpful, is maybe having a physical therapist home visit to come check your home and make sure that everything's well set up for you. But other than that, make sure that when you're walking, you move slowly and carefully, you check your surroundings, and you pick up your feet really high. I don't know if you can see my feet, but I'm doing it. Pick your feet up really high and move slowly, and practice walking that way with a slower, purposefully bigger step, and making sure that your foot clears the floor instead of shuffling along. Another issue that everyone faces sometimes, but especially dangerous if you have Parkinson's disease, can be a sudden lowering in your blood pressure. And usually that goes along with position changes. So you could be laying down and you have to go to the bathroom all of a sudden, so you get up really quickly and you kind of run off to the bathroom. And first of all, that rushing can cause a fall, so we don't want to be rushing anywhere. But also, if your blood pressure drops because you got up, then you won't know it if you're going too fast until you're halfway there, and then you pass out and land on the ground. So the best way to prevent the lowering of the blood pressure from positional changes, like when you get lightheaded and woozy, is to from laying down, sit up and wait a minute. Wait 60 seconds. When you first get up, wait and make sure that your head's clear, that you're not getting dizzy. Then when you go to stand up, you get your assistive device if you need it, you put your glasses on if you need it, and then you wait to see if you're lightheaded when standing before you start walking. Then when you get to the bathroom in that scenario, if you're constipated, which is another common problem, you want to make sure that you don't strain on the toilet. If you strain, that can actually create a lowering of the blood pressure where you pass out in the bathroom. Not good for anyone. Now Renee is going to show us what not to do when going into the bathroom with a walker. Do not turn around and try to back up. Backing up with a walker is very risky for a fall. And then what not to do is try to sit down too soon when you're not actually backed up to the walker, and then or to the chair, and then you fall. Okay, then we're going to show you what to do. Okay, what to do. So what Renee is going to do now is the correct way to go into the bathroom safely. She's going to walk in slowly, picking up her feet, making sure she knows where she's at. There's nothing on the floor. She's going to turn around once she gets to where she's going to sit down. She's going to back up until she feels the chair behind her legs, and then reach her hands back to grab the armrests or safety bars before she sits down. Another thing about bathroom safety and going to the bathroom, I talked about getting up and feeling like you have to go and then rushing in. If you have issues with incontinence, it's really important to not be rushing to the bathroom, so consider wearing a pad in your underwear or a diaper so that you can not worry about that, and you know you'll be able to, catch what needs to be caught by the time you get to the bathroom. That's, really important for fall safety, so you're not running. No one needs to be running to the bathroom. When it comes to constipation, since we're talking about bathroom stuff right now, there's a few tips that might help you not get constipated, and this is a common problem for people. One is to stay hydrated adequately. So of course, if you're on a fluid restriction for a medical issue, disregard. But if you are able to and allowed to drink lots of water, just sip on water, keep water with you throughout the day, and make sure that you're staying hydrated. That will help with your constipation. Also, if your stomach allows, eat more fibrous foods. So that includes all fruits, vegetables, whole grains, beans, nuts and seeds. Anything that you like that's a plant in its whole form has fiber, and those fibers can actually help you not get constipated. If you're having lots of issues, and if you have GI problems or restrictions with what you can eat and drink, it's important to go meet with a dietitian. And a dietitian can actually help you figure out what to eat so that you can move smoothly and regularly and not have to worry about the constipation issues. Finally, we want to talk to you about stress and lack of sleep. So the final thing I want to address when it comes to fall prevention and home safety is making sure that you're just taking care of yourself. Of course, having Parkinson's disease can sometimes be a stressful situation, And if you're not getting adequate rest, getting adequate sleep, taking care of your mental and emotional state, that, of course, if you're tired and stressed out, that can make us lose our balance, and that fatigue could put us at risk for a fall. So just make sure you're taking the best possible care of yourself. Thank you so much for your time and taking the time to be with us today. Again, my name is Rebecca Henson, and I'm one of the many great physical therapists here at Doctors Hospital. We love working with Parkinson's Place and Parkinson's patients, so we welcome you to come anytime you need a hospital stay. And also consider coming to our outpatient physical therapy department to learn more tips and tricks that are personalized to you. We do one-on-one care, and it's fabulous.
Thank you, Rebecca. And thank you, Doctors Hospital of Sarasota and CEO Bob Mead, for your continued support. Here's some information on some shoes you don't have to bend over to put on.
I've had Parkinson's disease now for about 14 years. And Parkinson's creates lots of challenges in my life. There's lots of things that should be simple that are not simple. One of those things that I've dealt with has been comfortable footwear. Kizik created a new shoe called the Madrid. It's a game changer for sure. It's my favorite Kizik shoe. I'm going to be sharing more Kizik shoes with you in the near future. So I'm going to stand up now, and I'm going to show you how easy these are to put on. I just take my foot and I slide forward and it's on. And I'm not very coordinated, but that's it. And they're good looking shoes too, but I feel like I'm floating on air right now. They're so amazingly comfortable. I hope you'll check out these new shoes called the Madrid. They're incredibly comfortable. They're by far my favorite pair of shoes, period, in my closet, because I probably have over 50 pairs. I've searched and searched and searched for shoes that are comfortable.
Thanks, Kizik. And heads up, everyone. Parkinson Place members and Summit attendees receive 20% discount on Kizik hands-free shoes. Just go to parkinsonplace.org.
Hi, I'm Ellie Baldwin, and this is my husband, Mark, and we're founders of Sunways Senior Living Concierge.
When it came time to find long-term care for my grandmother, we realized just how overwhelming that process could be. That's why we created Sunways, to offer others the resource we wish we had had.
Sunways Senior Living Concierge is a free service for families to navigate the maze of senior care. So whether you have an urgent need or you're just in the planning stages, we're here to help you know your options to make sure you're making the right choice.
We work with you one-on-one to help connect you with senior housing communities, in-home care, elder care attorneys, senior move managers, transportation companies, support groups, or whatever you may need, all at no cost to you.
To get started, go to our website at sunwaysseniorliving.com or give us a call at 941-867-0809.
And let Sunways be your advocate to get you the information and care that you and your family need.
Punch out Parkinson's with boxing. Parkinson Place brings Zoom and online classes and programs to you. Exercise your brain with trivia, music, and voice. Strengthen your body with yoga, balance, cardio, and dance. See all your friends and make new ones. Share in men's and women's peer groups and caregivers only club. Parkinson Place, your #1 resource in our area for people living with Parkinson's disease and caregivers. Sign up, it's always free. There's a new diagnostic test for Parkinson's, and C&D Life Sciences is here to tell you all about it.
Hello, Parkinson's Place members and guests. I want to thank you for inviting me to come here today and give this presentation. I'm Dr. Todd Levine. I'm a practicing neurologist in Phoenix, Arizona, and also the Chief Medical Officer for C&D Life Sciences. We want to talk to you today about a new diagnostic tool that we call the SIN1 test that we think will advance in the diagnosis and treatment of patients with Parkinson's and Parkinson's-related diseases. One of the things that we've understood about diagnosing diseases like Parkinson's disease and Alzheimer's disease is that we have no test that allows us to be sure about the diagnosis. What that means then is that during a patient's lifetime, we have to rely on clinical features, which can often overlap between different diseases. And then after someone passes away, we can do an autopsy. When we've done autopsy studies like this in Parkinson's disease, we find that almost 30% of patients that have been diagnosed with Parkinson's disease early in the course of their disease actually have something else, another cause for their movement disorder or their tremors. So much of science has really been geared toward trying to solve these diagnostic dilemmas to give patients and doctors better information to make the right diagnosis. At C&D Life Sciences, our mission is to help clinicians make the right diagnosis for patients and to do that as early as possible in the disease course. One of the best ways to do this in medicine is what we call pathology, which means looking at something under the microscope and observing a specific finding that assists us in making that diagnosis. We can do this at C&D Life Sciences through the use of a skin biopsy, which is minimally invasive, requires no stitches, easy for patients and doctors to do, and also significantly less expensive than other methods that currently exist. So what do we know about these neurodegenerative diseases? Well, if you look at Alzheimer's disease and Parkinson's disease as the two most common neurodegenerative diseases, and we look inside the brains of people that have passed away from these diseases, what we see are accumulations of proteins within the nerves. So on the far left of the screen, you can see Alzheimer's disease, and they have both amyloid as well as tau build up inside the nerves. As these proteins build up, the nerves can no longer function and they eventually die. In Parkinson's disease, we know that the protein that builds up is called alpha-synuclein, and other diseases such as the spinocerebellar ataxias can have even other proteins. But what all of these things share in common is that these proteins are folding incorrectly. They're not doing what they're supposed to do in the right place inside of the nerve as a result of this misfolding. So I want to take just a step back to try to talk a little bit about what is a protein and what is a gene. So all of us have chromosomes, and in those chromosomes are specific pieces of DNA. And that is the coding piece. That's sort of the software that says what needs to happen for the cell to survive. But the DNA actually undergoes a process of being transcribed into something called RNA. We've all heard a lot about RNA recently with the RNA vaccines for COVID. The RNA is then translated into a protein. It serves as almost like a railroad track that's read, and each individual amino acid is built to put the protein together. And it is the protein which does everything that our cell needs. So our DNA encodes for proteins, the proteins enact the thing that we need it to do. Now, once the protein is made through translation, there's a process that we call post-translational processing. And that means that that whole protein, the little squiggly line there, can actually be changed before it goes out and performs its mission. So one of the ways is through proteolysis, where it's cleaved or cut into different pieces. So you can make one big protein that becomes 2 or 3 smaller proteins that then go out and do what they need to do. There's a process called glycosylation, where we add sugar groups onto the proteins. And then there's a process called phosphorylation, where we add a phosphate group onto the proteins. And adding these little groups onto the proteins can significantly change the way that the protein behaves once it goes out to perform its mission. So let's talk a little bit about the synucleinopathies and what we mean when we say a synucleinopathy. What we mean is that we now know of 5 different diseases in which the protein alpha-synuclein accumulates inappropriately inside the nervous system. The most common is Parkinson's disease, but we see it with dementia with Lewy bodies, multiple system atrophy, pure autonomic failure, and REM sleep behavior disorder. Taken as a group, we call these the synucleinopathies. If we look at Parkinson's disease, we've understood that synuclein is at the heart of this for a long time now. So James Parkinson first described the disease in 1817, so almost 200 years ago. Almost 100 years ago, a pathologist named Lewy described these Lewy bodies, since they were named after him, these accumulations of proteins inside the nerves, as being the hallmark pathology for Parkinson's disease. In the 1960s, we realized that this accumulation of these proteins, these Lewy bodies, led to not enough dopamine being produced in the brain. And that then led to the ability to prescribe L-Dopa as a way to symptomatically treat people with Parkinson's disease. But almost 30 years ago now, people realized that the main protein inside those Lewy bodies, which we've known about for 100 years, is the protein called alpha-synuclein. This is what alpha-synuclein looks like if you looked at the entire sequence of the amino acids. It's about 140 amino acids put together. And what we now know is that at the end of the protein, sort of around number 125 through 136, there are 4 places where that phosphate group can be added on through the process of phosphorylation. And that process of being phosphorylated at the end of that protein seems to allow the protein to fold incorrectly, and the misfolded protein then starts to accumulate, and you build up more and more and more synuclein inside those nerves. This is a very rough schematic of what we're talking about. You produce the alpha-synuclein protein. The DNA becomes RNA, the RNA becomes protein. If it folds correctly at the top, you can have a nice origami-shaped boat, and the protein goes out and does what it's supposed to do. If the protein folds incorrectly, the process of misfolding, then it becomes toxic. And it's not only toxic because it's a bad protein, but now as a bad protein, it causes the other good proteins to fold incorrectly. So it's one of those they told 2 friends, they told 2 friends, they told 2 friends kind of thing. And very quickly, that can build up and it starts to become damaging to the cell. Then as that cell dies, those misfolded proteins leak out into the nearby cells where they're taken up, and they cause those proteins to fold incorrectly. So how do we look at this? Well, we could certainly look at it by doing a brain biopsy, not very convenient or very safe. So one of the things that's emerged over the past couple of decades is the ability to take a little skin biopsy. And you can see here next to the quarter that that's a very small piece of skin. Using the skin biopsies that we obtained, we're able to view the nerves in the dermis. If you look at B, what you see are longitudinal axons. Each of those green lines is an individual nerve. And then above that, using immunohistochemistry, we're able to stain for the phosphorylated alpha-synuclein, which, as you remember, is the pathologic form. We can then merge those 2 images together, and you get the orange at the bottom. And what that tells us is that that abnormal protein, the phosphorylated alpha-synuclein, is absolutely contained within the nerve. You can see the same on the right. The other thing that's really important about this is it shows how the nerve is longitudinal, and the proteins actually build up inside the nerves. So they're not spreading through blood vessels, they're spreading along the length of a nerve. And this really goes along with one of the big theories about the pathogenesis of Parkinson's disease, which is that it gets into the nerves inside the gut, in the stomach or intestines, and then over years spreads slowly up through the nervous system until it finally gets into the brain, and that's when it causes the motor symptoms. So we believe that that's the reason that patients will have constipation, for example, long before they have any of these motor symptoms. But these are highly specific, and the finding of this phosphorylated alpha-synuclein tells us that this person has a synucleinopathy. So taking this technology, which really has developed over about 2 decades, we were able to develop the test that we call the SYN1 test. We introduced this test about 1.5 years ago, and it's now been used by neurologists in over 20 states. It's convenient, as I said, a small little skin biopsy, well proven by labs all over the world, and very accurate. We believe that we have a 95% sensitivity and a 99% specificity. We're now getting good payments from Medicare and other providers to help support patients who need to get this test done. And we also recently just won a large NIH grant to study and further push the limits of what we can do with this test. The SYN1 test has a number of significant benefits for patient care. Number one, it allows the doctor to actually see the pathological process that's going on inside of your nerves. That gives the doctor an insight that they've never been able to have before. And that allows patients to have much more clarity about their diagnosis. Some of these are particularly bad diagnoses. We don't yet have cures for these diseases. So sometimes it's just a matter of having a better plan for one's life, knowing what to do in terms of your lifestyle behaviors and so forth. And then in some cases, it's the doctor being able to choose the appropriate symptomatic treatment regimen. Another point that's very important here is that if we have the test and we're able to make the diagnosis, we don't need to send people to multiple other doctors trying to get an answer, or multiple other tests or procedures, some of which may be invasive. We also see this as being very important in clinical trial eligibility. There have been a number of trials for Parkinson's disease that we thought could slow down the progression that have failed. But again, if you go back to the point that I made in the beginning, which is that it is possible that 30% of patients that we've diagnosed with Parkinson's disease actually have another disease, you could see why these clinical trials would fail unless we're enrolling the right patient population. And so we at C&D Life Sciences are working with a number of different pharmaceutical companies to try to help improve clinical trial design and also improve the way that we assess whether or not the drug is actually effective. This is what our reports look like. In the top right, you can see where it says phosphorylated alpha-synuclein, abnormal. The finding of phosphorylated alpha-synuclein is 100% pathologic. That means if we see it, there is definitely a problem there. We also look for a number of other conditions, including neuropathies, amyloid, and then routine histological changes that can occur in the skin. All of this is provided to the doctor, along with pictures of each patient's individual pathology. So your doctor can review that with you if they want to do so. So how do we think about this test at C&D Life Sciences, and how are neurologists across the country thinking about this test? This is sort of our representation, what we call the SIN1 wheel. So imagine you have a patient that has a tremor, and you're uncertain whether it's an essential tremor or a Parkinson's tremor. By doing the biopsy, if the biopsy is abnormal, that places your patient into the middle wheel there, meaning they either have Parkinson's, dementia with Lewy bodies, or multiple system atrophy. If the biopsy is normal, it places them in the outer part of the wheel, telling them it could be essential tremor or other conditions such as progressive supranuclear palsy or cortical basal ganglionic degeneration or normal pressure hydrocephalus that are not synucleinopathies. So this test gives the doctor a good look at what type of illness this is most likely to be. As we think about patients with cognitive impairment, the two most common dementias are Alzheimer's disease and dementia with Lewy bodies. They have very different prognoses. People with dementia with Lewy bodies do significantly worse. So again, early in the disease state, using the SIN1 test, we can tell whether or not that patient is more likely to have dementia with Lewy bodies or more likely to have Alzheimer's disease, which can help the family plan for what's going to be coming for that individual. We also are very widely used for patients that have autonomic dysfunction, those autonomic nerves that control the blood pressure, the heart rate, the digestion, all of things that are clearly affected in these disorders. But they are caused by other things other than synucleinopathies, such as diabetes or amyloid or autoimmune causes. Again, doing the SIN1 test, if it's abnormal, places the patient into the middle of that wheel, not on the outside. And then in sleep disorders, we talk about a number of different sleep disorders, and REM behavior disorder being the synucleinopathy that we would be concerned about. So it's really a way to provide the clinician more information, a way to look into the nervous system of the patient and give them another tool to help make the best possible diagnosis. So briefly, in conclusion, we think this is a very objective, convenient diagnostic tool to help diagnose the synucleinopathies. It gives the clinician proof that there's something going on in the nervous system and allows them to discriminate amongst different diseases as well. We at C&D Life Sciences are collaborating with researchers to continue to try to advance the science and hopefully find better therapeutics by having an appropriate biomarker, and then allow us to detect the disease even earlier. So one of my particular passions with this test is the hope that we could actually find these diseases 10 or 20 years before a patient becomes symptomatic, and thereby prevent these diseases as opposed to just treating the symptoms. I want to thank you for your time. I hope you found this to be helpful. We do have a lot of this information on our website at cndlifesciences.com, and I hope you have a great day.
And now, a very special guest. Welcome Parkinson Place member and sign language instructor, Deborah Brenner.
Hello, my name is Deborah Brenner, and I am a member of Parkinson Place. I exercise regularly with Alex Redmond, and at the end of every class, we share a very powerful affirmation. I believe I can do anything. I know sign language because of my career path, and I would like to share the affirmation with you in sign language. I believe I can do anything. Now I'm going to slow it down, and you can do it with me if you'd like to learn it. I believe. You take the thoughts and you put them in your hand. I can do anything. Let's try it again. I believe I can do anything. Now, let's give it a try and see if we can do it up to speed, but no voice. Thank you so much for sharing.
Let's continue the conversation. Tell us what you thought about the summit. You can send us an email at summit@parkinsonplace.org, post a comment on our Facebook page. And, as we mentioned before, we really care about what you think. Please take a few moments and fill out our survey at parkinsonplace.org. On behalf of our team, thank you for attending the Parkinson Place Virtual Summit 2021. Check us out at parkinsonplace.org, sign up, become a member, and connect. We look forward to seeing you.